Seeing we now have a quorum, I'll call the November 1st regular meeting of the CalOptima Board of Directors to order. And I'll ask Dr. Nguyen to lead us in the Pledge of Allegiance, please. Please stand.
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And Madam Clerk, would you please establish a quorum?
Dr. Yost?
Here.
Dr. Katibi?
Here.
Berger? Here. Mr. DeLuigi?
Here.
Supervisor Doe, I believe, is on his way. Dr. Nguyen?
Here.
Mr. Penrose?
Here.
Mr. Sanchez is not here yet. Mr. Schofel? Supervisor Steele? We have a quorum.
Madam Clerk, as a reminder, the agenda indicates, this meeting is being live streamed on the caloptima.org website. And with regard to public comments, forms are available at the back of the room. To speak on an item, please submit the form to the clerk of the board, list the item that you would like to speak on, and but the comments must be germane to the subject matter jurisdiction of the item upon which you're speaking. If you want to speak at general public comment on an item not on the agenda, you are certainly free to do so. When addressing the board, please state your name for the record and address the board as a whole through the chair. Comments to individual board members or staff are not permitted, and speakers are limited to 3 minutes. Also, I'm going to reorder the agenda to hear item 22, the joint MAC and PAC report, before discussing items 3 and 4, especially since we asked the MAC and PAC to have a meeting to get their input before we discuss that. So it seems like it'd be rational to have them speak before that. Michael, we have no presentations today. Would you like to highlight any of the items included in your CEO report?
Sure. So good afternoon, Chair Yost and members of the board. First, I'd like to start by introducing our new Chief Medical Officer, Dr. David Ramirez, who joined us on Monday. Dr. Ramirez has an impressive background, and I invite him to say a few words.
Welcome.
I'd like to start by saying how excited I am to be here and for this opportunity. I'd also like to thank Dr. Richard Helmer for his many years of service to CalOptima and our community. A few words about my background. I attended Stanford University and Harvard Medical School. I completed my residency in internal medicine at Cedars-Sinai Medical Center. And I spent 10 years in Austin, Texas, initially as a private practice hospitalist, and then as a faculty hospitalist, primary care provider, and medical director with the University of Texas and the Seton Healthcare family. I came to my senses in 2012 and relocated to Orange County. And I've spent the past 6 years with CareMore Health in a variety of roles, leading up to being Chief Quality Officer. Throughout my career, I've focused on improving patient care, and I look forward to working with the board, my colleagues at CalOptima, the provider networks, and our community partners to better the lives of our members and impact our community in a positive way. Thank you.
Welcome.
So the January 1 transition date of the California Children's Services Program to the whole child model is fast approaching. The 90 and 60-day advance notices were mailed to more than 13,000 Orange County families, informing them of the upcoming transition from the healthcare agency to CalOptima. In October, CalOptima hosted 5 family events in 5 locations across Orange County with involvement from our health network partners. We also sent a representative of our Family Advisory Committee to training in Sacramento that was hosted by the Lucille Packard Foundation for Children's Health. And our next stakeholder event is on November 7, and more than 100 are expected to attend. CalOptima continues to help hospitals prepare for the federally mandated statewide transition from the quality assurance fee to directed payments. I attended a meeting in Sacramento to advocate alongside with the California Hospital Association so that our community receives maximum funding to support our CalOptima members. In addition, we invited a vice president from the California Hospital Association to our quarterly meeting with health network CEOs, and she provided details and helped answer questions. Moving on, the proposed DMHC regulation on general licensure requirements for healthcare service plans does not impact CalOptima directly, but could potentially impact some of our health networks. There has been a broad public comment on the proposed regulation, including from our two associations, the Local Health Plans of California and the California Association of Health Plans, as well as from other associations, including the California Hospital Association, California Association of Public Hospitals, and America's Physician Groups, which includes many of our health networks. On October 9, the Office of Administrative Law, OAL, disapproved the proposed regulation based on failure to comply with the clarity standard. DMHC has 120 days to make changes, hold another public comment period, and resubmit the regulation to the OAL. Last week, this issue surfaced at a board meeting I attended of the Local Health Plans of California, and DMHC Director Shelley Roulard attended but could not talk about the proposed regulation because it is in the rule-making process. At this point, we are awaiting new language from DMHC. Depending on how global risk is defined, there are potential options to ensure the stability of our delivery system. For example, taking away the downside risk from our PHC risk pools and eliminating the carry-forward provision of our SRG agreements. And we'll be adding this item on the DMHC regulation to our future, as an agenda item to our future health network forums, so that we can keep everyone informed, and if there are opportunities to collectively advocate, we will. Today, CalOptima launched the process.
I said, Ron, you want to make a comment?
Question on that, unless
Sure.
you want to hold it till the end.
Go ahead now if you
All
want. That's fine. Go ahead.
Michael, on the Knox-Keene licensing regs, you know, we all understand just how significant this is to us. I mean, CalOptima has been granted pretty significant authority and autonomy in Orange County, and I think that clearly the proposed reg in its previous form threatened that and was of great concern. So I appreciate your raising that again today, and I would ask that let's stay really plugged in on this. I'd like to hear back as it's moving along.
Sure.
And I think your final point about the opportunity for collaboration with our health plan partners and with our provider partners and others who are very, very interested in this, and us being able to, I think, maintain the role that we currently have. So, you know, in terms of waiting, we're waiting for clarification, but quite frankly, I'm hoping for much more than that. I think from an active perspective, we want to make sure that that clarification is consistent with the enabling authority that we've enjoyed in the past, and is not changed, and that our delivery system is not negatively affected. So whatever you can get, whatever information you can flow back to us too, I think I'm certainly interested, and I suspect all the board members are.
Yeah, but we were just kind of chatting about this earlier. We were talking about, you know, we're really encouraged by your, you know, advocating along with the Hospital Association of Southern California, going to Sacramento and lobbying. But, you know, there are other entities that can definitely help with this, particularly CMA, OCMA, and I think looping them in. If we can pool our resources, you know, when we consider advocacy and lobbying, we don't just consider legislative, but regulatory as well. So. Yeah. I know within our entities, we have extensive contacts within the various regulatory entities. So I think forming a group together, and this is a a great opportunity for us to work together. I think there's nothing like having an outside person for us to have to deal with to bring us closer, especially with some of the points of contention we had recently. So I would strongly recommend, reaching out to the networks, reach out to the HASC, reach out to OCMA, and reach out to the networks and put together a group that can advocate in that direction. It'd be absolutely wonderful.
Mr. Chair.
Yeah, go ahead.
You're right. We should work with other agencies and groups, industry groups. But this board hasn't had a policy decision. So when Michael meets with people and go and advocate on behalf of CalOptima, what is he advocating and what? Because I certainly don't know what position we take. And have we taken action as a board? And if we haven't, what is staff advocating?
Well, I think the primary is, directive for us is to make sure that we have a network that provides care for our members, and that they stay together. And with the potential changes to the regulation, it potentially puts enormous costs and puts our whole network and provider system at risk. And I think that's part of our base mission as part of CalOptima, providing cost-effective care for our members. And I think that this definitely puts that squarely at risk. I don't think there's an alternative perspective in addition to that, unless other board members have a feeling, but that's our primary directive.
Well, you're in the industry, so you may know all the nuances of that, but I certainly can't profess to know all of this, the mega reg and all of the Knox-Keene issues involved. I think it would be beneficial for this board to, at some point, be fully apprised as to what that means and what position are we taking.
Okay.
And what would be the potential consequences, right?
Yeah.
Because there are more aspects to probably just the licensing aspect of it.
Yeah.
And there are some components of that that should be broken down so that we know exactly what we stand for. And we may end up agreeing, but we should at least have one opportunity to say that, okay, we agree with you, Michael, you go and advocate in this direction. I just don't think we have done that. And so it's kind of confusing when we talk about that.
You know what?
Hang on one second. We'll go 1% at a time. Lee first, and then Ron. Okay, go ahead, Ron. Go ahead.
Well, I was just going to say the push we're talking about here is important, and certainly if we need to refresh. But help me remember. I thought this issue was raised amongst the board in a couple of our larger discussions. I remember it was kind of began with the meeting when Director Kent came down and made a presentation to the board and intimated this potential risk. We were very, very aggressive and very strong in terms of our position around the statutory authority that we believe we have. That said, regulations can get into all kinds of different machinations and can cause us difficulty. But I thought that we followed that with a pretty clear effort. But maybe it's worth refreshing what we did in fact indicate at that point, because we came out very clearly opposed to any efforts, any activity that would preclude our authority by placing onerous and additional responsibilities and requirements on us, particularly the Knox-Keene requirements. But even, and then this gets to the point of the broader healthcare community, some of the machinations they were doing on this other reg kind of goes around some of that and even potentially targets our own plans. That's a problem. That's a problem for our autonomy and our ability to do that. So I think if we need to refresh the board on some of that, that's going to be important, because this is key to us.
So,
and also, in addition to that, Gary put out a very nice, very thoughtful, well-researched, about a 30-page, briefing on the issue specifically too, for all our board members to kind of review for kind of late-night reading before you go to sleep. But I think having it come back to the board the next meeting for a thoughtful discussion is absolutely a wonderful idea. I have no problem with agendizing that to the next meeting.
And the basis is that the proposed regulation would, while not impacting CalOptima, would potentially require that our health networks with the shared risk group agreements and with the physician hospital consortium agreements, that those health networks would potentially need to acquire Knox-Keene licenses. And that can take a lot of money and a lot of investment. And so I think what all of the associations are asking, if not outright opposing, is why? What's the benefit? How does it help members? And so that's what CalOptima is also looking at, trying to understand from the department.
And just go ahead, Mr. I mean, this, in addition, this has been an issue since I was on the board, 10 years ago as well. So go ahead, please.
I guess what I'm getting at is we have some kind of deadline at the end of this year, right? Or do we? Is this something we can just continue?
Well, I think based on the dismissal from the OAL and the 120 days, that I wouldn't think that end of the year date is going to stand. I would expect that's going to be pushed out to some extent.
So the reason that I'm bring this as an issue is this. Usually there's a plan of action for us as a board, right?
Okay.
If it happens, what do we do? If it doesn't happen, then what do we do? If the regulation is changed and it does apply to our networks, then how much time each step would take? So that way this board know full well how to proceed going forward. I'm asked to rely on a memo, and the conclusion of the memo is that it may require that we seek an exemption from the HC. I'm like, that's no way for me to plan when the memo conclusion is may. So that's why I'm asking you to bring to this board what are at issue.
Sure.
And then give us options, like a flow chart as far as how we should proceed as an agency going forward.
Okay.
Okay, that's it. Because I kept reading this back and forth, and I don't have a conclusion. And I know you don't know where the regulation is going to fall. I know that.
Right.
But that's why we need to know ahead of time. Okay.
Okay. Go ahead, Lee.
Thank you. I will jump in just a little bit. I think there's a couple of things a question here. One is sort of the legal, the regulation. What are we and what are our networks required to do? And the other is that what is our position on this? I think it would be a good idea, given the discussion, to come back with an information item and let's get some more knowledge of what would the implications be. What would the cost to our networks be? I think we have a couple of networks that have Knox-Keene or limited Knox-Keene license, but certainly not all of them. And you're right, Mr. Schrader, the resource required would be an extreme limiting factor. I think my perspective is once this board sees all that's required of a network to seek out and apply for a Knox-Keene license, I think there will be a revelation that we do need to oppose that and advocate against as much as possible. But if we all need to get there through an information item, I'm all for it.
Awesome.
And again, Mr. Chairman, the reason I raised it to begin with is that I guess I'm already convinced we got a major problem coming down the track on us here.
Yeah, I think so.
I'm anxious to get into a little bit more of an aggressive advocacy mode.
Yeah.
I appreciate the supervisor and the other board members wanting to get a better sense. And so I fully agree with, like I said, a refresher, redo it again next week. But let's not, just because this is a regulation, let's not assume that it's out of the realm of advocacy.
Yeah,
There's a lot that we can do. There's a lot that we can do in conjunction with our partners to try to preclude what we're calling clarification here. I'm not sure that we're going to like the clarification. So I don't want to be, that's the caution I'm posting. I just, well, let's bring it back. Let's go ahead and have that discussion. So we as a board are comfortable and we're all in the same realm, but we definitely need to get moving. This, notwithstanding OAL's action, this is coming back.
Go ahead, Michael. I'm sorry.
Two more items. Today, CalOptima launched the process for independent PACE organizations to request a letter of support. Our website includes a document explaining the process. with detailed instructions on the information that must be included with any submission. The 2-month window to submit request closes on January 31st, and staff will evaluate the request based on board-approved criteria and bring the results to a future meeting. And then CalOptima received more accolades for the quality of care that our members receive. For the 4th consecutive year, the California Department of Healthcare Services presented CalOptima with the Outstanding Performance Award for a large-scale plan. So thanks to your board for your leadership, to staff, and to our provider partners for all the hard work behind this recognition. That said, we always want to improve, and continued improvement rests in part on our ability to continue keeping members informed about the importance of obtaining preventative services. Towards this, we're launching a quality of care outreach campaign to promote prenatal and postpartum care, childhood immunizations, behavioral health, breast cancer screenings, and well care visits. So the 6-month campaign will include print advertising, billboards, transit shelters, OCTA buses, and social media. And the cost of the campaign was included in your board-approved budget for this fiscal year.
Thank you, Michael. Any other comments on the board?
Michael, if there's
Go ahead. Go ahead.
if there's room to consider peripartal use of like opioids or heroin or substance use, that might be a good idea.
Okay.
Supervisor?
Mr. Chair and the board, I would recommend that we look at the marketing budget and how we do ad campaigns, and there should be more board oversight. The process, as I understand it now, is there's an item for marketing for the year that's brought to the board, and then there's a cumulative dollar amount with some general description as to products that we're trying to advertise. But within each product line that we advertise throughout the year and events that we do is completely up to staff discretion. And the threshold is $100,000, right, Michael? Before it has to be brought to the board? It's a CEO's discretion, right? Up to $100,000.
There's if it's less than 50,000 in terms of procurement, there has to be at least 2 bids, and if it's over 50, there has to be an RFP.
Okay.
Yeah.
And
That's
but the thing is, when we do advertising, even if it's to the same media outlet, and we have multiple products, what we would consider at the county would be to break up the contract, and not that it's intentional. I'm just saying that it would be broken up, so it would always be below that threshold. So we ought to have a process where the policy should be more well-defined, that if it's that collectively, cumulatively, if it's a certain amount to a certain outlet, that would be combined together so that it reaches a threshold so it gets to the board supervision. We don't want a situation where we have multiple contracts to the same provider, 8,000, 5,000, 2,000, none of which would ever exceed the threshold. But by the time you're done, they could spend $60,000, $70,000 a month to the same vendor completely without board oversight and within staff discretion. So right now, am I describing it incorrectly?
Sure, and one of the things we've started to do is include in your weekly updates an update on the marketing, the outreach that we're doing, and the different newspaper, radio, TV advertisers that we're using and what the cost is.
Right.
So
I asked Michael to do
we could
that.
expand that.
Right.
Certainly.
I asked Michael to do that.
Yeah.
Up until now, we never had it. And so instead of just catching it after the fact, I am asking this board, I'm suggesting that maybe you put together an ad hoc, look at the policy and see what's the best way for the board to maintain proper oversight, or at least in more accountability in terms of transparency on how those decisions are made. Because we have that situation where spending went up significantly within a very short amount of time and nobody knew about it until months later.
Go ahead, Rhea.
And I'd like to echo what Supervisor Doe had just mentioned. I think besides the cost part of it, is also the delivery and the messaging. And we all have different platforms for different campaigns. And it would be really nice if we consolidate that, and it's a more concerted effort, and it would be a cleaner way to roll it out. I mean, because I agree, there are different kinds of funding opportunities that are going through the pipeline. It would be really nice to kind of, like I just know, for instance, like with oral health, we're working with Orange County Healthcare Agency on this, and we're talking about the same thing. You know, we're talking about bus wraps and social media and everything. And it's all for the children's campaign that you're putting together. So why are we segmenting that out when it should all be part of that same thing? So I think a more strategic approach and a cleaner flow chart or a roadmap for marketing campaigns with cost dollars, I think would be very beneficial for our board to see.
We can discuss this now, yes, because we're going to direct staff to come back with something for the next meeting. You know, in terms of marketing for CalOptima as an organization now, do we have a marketing department per se? How does it function within the organization right now?
We do have a very small team, and it's mostly around PACE enrollment and enrollment in our Medicaid, Medicare program is where we do marketing.
Right.
And then besides that, there can be general outreach, mostly around quality, to improve quality of care. And in that case, we're typically focused in on certain HEDIS measures that we want to improve. Can be along the lines of preventative care.
What is our overall marketing budget? Sorry to put you on the spot. I should ask this. Do you have an idea as to what that is?
We can bring that back.
Well, why don't we bring that back and we'll agendize that as an item to see. I mean, there's a lot of potential pitfalls to in doing lots of different things, and it might even be better to outsource it to a complete outside entity that's free of other types of issues, that just has our best interests of marketing our services, which is what a lot of entities end up doing. There are a lot of wonderful marketing companies out there who can help us with that if we need to. So when we bring that back and find out what our total budget is and discuss it, because I don't know off the top of my head. Is that reasonable for the board? Yeah, so we'll bring this. We'll put that back on for the December meeting.
Sure.
Okay. Anything else?
Oh,
okay.
Thank you.
That's a lot. Okay. Public comment, Madam Chair. Do we have any requests for public comment?
We have no requests for general public comment. However, we do have requests on agenda items 3 and 4.
Okay. All right. We'll do those at the time before we hear those items. And for the consent calendar, for the record, all consent calendar items are approved by one motion unless pulled by a board member for discussion and separate actions. It's only one item, and that's consider approving the minutes of the October 4th regular meeting. Can I have a motion to approve the consent calendar?
Move approval, Mr. Chair.
Move approval by Mr. DeLuigi. Second by Mr. Schoeffel, Director Schoeffel. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. And then, as we previously indicated, we'd like to reorder the agenda to hear item 22, which is the joint meeting from the MAC and PAC. And, you know, as a reminder, before we hear from our committee leadership, recall over the past couple of months, we have been discussing issues of the auto assignment cap for our community care network and the possibility of evaluating CalOptima healthcare delivery system and hiring a consultant to assist us with that process. Also, as part of our stakeholder vetting process, we directed staff to include these items on the MAC and PAC agenda, in addition to the committees that chose to have a special meeting devoted to further discussion on these topics, and that occurred on October 11th. So let's hear from our committee chairs with regards to that. So we have Sally Molnar and John Nishimoto. And I think the board all received some correspondence in that regard as well.
Hi, good afternoon.
And by the way, thank you for your service and thank you for your input. So.
Oh, thank you. Appreciate that. I'll start out from the MAC perspective, and I want to say that both committees put a lot of time and effort into arranging this joint meeting and thoughtfully discussing these two items that the board proposed to us. And from a MAC perspective, I just want to start out and saying that, like, our largest concern, I'm going to start out with the delivery system, was that we really didn't see what the purpose of doing the review at this time was. We have been rated as the top plan for 5 years in a row, so obviously we're doing a great job delivering services to our members. And our MAC members are people that represent our members out in the community. We work with them on a daily basis, some of us, in our community-based organizations, and in some cases, our jobs. And we find that the membership is generally happy with the care they receive from CalOptima. So our concern was, what's the purpose of doing this now? And in addition to that, there was no cost associated with doing the review. We kind of were led into the discussions, Lonnie, how much was this going to cost? Was it $100,000, $50,000? And so there was a concern about that. There was also a concern with the resources, the human resources it was going to take, both in our provider network and with our CalOptima staff, if we had to go into this lengthy review process of the delivery system. So from the member perspective, we just didn't really feel like we had enough information, and we had too many concerns to feel like it was a good idea to move forward with recommending an evaluation at this time. And I'll let John chime in here.
Sure. So good afternoon, Chair Yost and distinguished members of the board. Again, on behalf of the PAC, thank you very much for allowing the committee to provide input on these areas. We did have a lot of lively discussion, a lot of input, and I think we were actually vetting areas quite thoroughly. As you can see in the joint MAC, OCC, MAC, PAC report, there was a lot of discussion, public comment, and then you also have the recommendations and conclusions from what the meeting came about. And then in regards to conducting a review in the delivery system, I don't think I have anything more to add of what Sally had mentioned. I think the overarching sentiment was a potential disruption in membership access for care, the amount of staff resources to properly collect information during a time in which examples, the whole child model and health homes programs initiatives are rolling out. Committee members really discussed about the quality of care CalOptima was providing, ranking the top-rated Medi-Cal program. And while we all feel, I think everybody in this room feels continuous quality improvement is really necessary to ensure the highest quality. Currently, there's many metrics, analytics, reviews in place. So those are some things that we wanted to consider at this time. And then when we started thinking about the auto assignment as well, I think one thing that really resonated was when our PAC member, Jenna Jensen, reminded us of the ordinance that CalOptima is under. It really provided perspective as well, and I think a change in the auto assignment could potentially create a competitive situation with the networks and providers, and we wanted to be mindful of that. So,
okay, and then my thoughts on the auto assignment from the MAC perspective was that, first of all, we're a little bit concerned that we have 7,000 members a month not selecting a network. So that in itself is a problem. But we heard from a public comment and from one of our PAC members, Dr. Sweden, who's a physician member on the committee, that there's referrals that are made to some of these CNN physicians, and they're turning patients away. They're not accepting them. So it actually was like a red hot poker, this discussion. So it got a little bit heated in there. So from our perspective, I don't think that there's a need to make the change at this time. I think if we really want to look at auto assignment, if we have the ability to do reviews of systems, maybe this is a system that needs review, maybe this is a system that needs better marketing or outreach or something to newly enrolled people, so we don't have 7,000 members a month falling into being auto assigned. And then concluding, our members do have a choice to choose which network they're in, and they also have a choice monthly to make a change to that. So we didn't see a need to make a change to the policy at this time. Anything else? Okay, any questions?
Any questions from the board of our MAC and PAC? Had solicited their input, so. Thank you, both of you. Okay. And then
Can I,
Supervisor.
no questions, just comments, or is this the right time? I'll leave it up to you.
If it's okay with you, why don't we just go on to item 3 really quick, and then,
okay.
is that okay?
Right.
All right. Madam Clerk, would you, well, as previously stated, we're going to hear item 3. Madam Clerk, would you please read the item?
Consider authorizing removal of the 10% auto assignment limit for the CalOptima Community Network and revise policy EE1106, Health Network and CalOptima Community Network minimum and maximum member enrollment to reflect such changes.
Okay. And then we have some public comment on this particular issue too, correct? And then
Yes,
we'll
we
do board
do.
comments after the public, if that's okay. Go ahead and call them, Madam Clerk.
The first person, Paul Soroti.
Welcome.
Good afternoon, Chair Dr. Yost and members of the board and audience. My name is Paul Sarode. I'm a PCP pediatrician, also do pediatric critical care. And I've been in Orange County for a long time, since inception of CalOptima program. And I'm here to represent independent physician of this county. You can consider me as a sample physician. I'm here to address the letter written on October 4 and was signed by 11 physicians in support of lifting the auto assignment cap limit on the CalOptima Community Network. This letter was provided at the Joint Advisory Committee meeting and is included. I think most of you are familiar with that. As a practicing physician, I'm concerned the CalOptima board would consider making this policy change that would negatively impact health networks. The overall membership trend shows CCN network is growing faster than the health networks, and there is no evidence to support the statement that CCN needs to be continually refreshed. All health networks and CCN providers need to have a stable membership to remain financially viable. We believe that CCN has achieved this stability and is not held to the same financial constraints as the health networks. The current auto assignment policy rewards the health networks to achieve high quality and performance standards. The presentation by CalOptima staff ranks CCN 9th out of 13 networks. We do not think that making a policy and unilaterally assigning more patients to a low-ranked network is something board would want to support. Finally, CalOptima was recently recognized as a top medical plan in California, which could not have been achieved without the contributions of providers and the healthcare networks. We know this achievement is highly regarded by the board and I would not think that the board would want to impact this by opening up CCN network to further growth. And if I have your permission, I can make further comment on report item number 4.
We'll hear the discussion at item 4, if that's okay with you. Did he fill out speaker card for 4?
Yes.
Let's wait till we hear the staff report and everything and discussion of this before we hear item 4. So we'll have you come back when it's time to comment on item 4.
Great, thank you.
Thank you. Thank you, Paul.
Hello, good afternoon to the board. I am Dr. Fukmin. I am practicing primary care and internal medicine in Orange County here for about 15 years. And I'm also sitting on the board of Family Choice Medical Group. And I'm here today representing Family Choice Medical Group, voicing our concern with CalOptima proposal to lift the 10% cap for the CCN network. I believe that since the inception of CalOptima, the intention was to improve coordination and quality of care for our underserved population, and while keeping the healthcare budget under control. This model of care has been proven to be quite successful, as many of our networks were able to achieve these objectives. An example is demonstrated by our network, Family Choice Medical Group, through tight collaboration with hospital, efficient management of the key programs such as hospitalists for inpatient care, and for the post-discharge skilled nursing care. We were basically able to achieve a very short length of hospitalization for our members, as well as keeping a very low rate of hospital readmission. We were able to accomplish this while having one of the lowest patient complaints and also one of the highest provider satisfaction among the networks managed by CalOptima. I believe CalOptima has done a commendable job in coordinating and facilitating, and I believe the key word here is coordinating, the medical networks to continue to improve patient care and to encourage participation from providers through the network, participating networks. And CalOptima's, however, attempts in direct patient care through the opening of CCN network, I believe this has not been too positive. Contrary to what you have heard, the providers' participation and satisfaction, what I have heard and seen, they weren't too rosy for that. I had opportunity to review some of the data showing the members' complaint and the providers' complaint among the networks. The network's quite high. So to conclude, lifting the CCN 10% cap for CCN membership, I think it will create basically roll back the progress of what we all have achieved through the years. It will create basically a network monopoly through various methods of auto assignment, and possibly trigger a downward spiral of quality health care for our patients. And that's all I have to say.
Thank you for your comments.
Reginald Abraham.
Good afternoon, Mr. Chairman, members of the board. I'm an independent practitioner. I'm a cardiovascular and thoracic surgeon. Not easy for me to take time out of my day, just like yourselves, to come here and present at a formal meeting like this, but I have some concerns. So this expansion of the CCN, I don't have a dog in the fight in terms of belonging to any particular HMO or IPA or things of the sort. But who I'm fighting for is hopefully who we're all fighting for, which is our patients. Anything that's going to limit their choice, I'm suspect of. And if we grow this program, we're going to take away the patients from those IPAs, all of whom I've been in touch with, in contact with, to find out how this has impacted them. These are patients we see chronically, not just in the anesthesiology OR, not just as pain management, but patients that you see on a regular basis in the community. I don't think it's not disconnected. I don't think it's disconnected that, in fact, the patients that have grown within the CalOptima network with this 10% group has diminished and taken away from the IPAs, the same amount of people. I haven't yet seen data to suggest that the information collected with regards to satisfaction is objective. It's done internally. There's no reports of lesser length of stay, no reports of lesser ER visits. And certainly the numbers of patients that they've grown by is matched by the number of patients that have diminished in all the IPAs. Ultimately, maybe it's my suspicious mind, but I'm very concerned that this is a backdoor way into a single payer network, which I don't think a lot of people are in support of. So with that, I urge you to be very concerned about patient care, who manages this care, and also there's no coordination of care. Currently, all these IPAs have nurse practitioners or someone to help coordinate the care. To say that the physicians are going to do this is unrealistic and has never happened. So who's going to suffer? Patients. So I would urge you to strongly look at all these individual parameters, not with a wide swath and broad strokes, but drill down to what exactly is going to happen to those patients. Thank you.
Thank you for your comments.
That's it.
Let's go ahead and provide a 3. Okay. I'll open up to the board for discussion. I'm going to start with actually Dr. Katibi next to me here, since this was something he put on the agenda to, to bring to our attention. So go ahead.
Sure. Thank you so very much, Chair Yost, and thank you to our speakers today for coming out and expressing your thoughts and perspectives. I would not be doing my position justice as a board member for CalOptima if I did not bring this topic up. In part because although I do wear the hat of CalOptima, I would have to be respectful to my predecessors who structured this board in a way to make sure certain populations were especially represented. I was appointed to serve on a seat that represents the community care network, the community care doctors. And so people have approached me many times in the CCN and said specifically, hey guys, we have some concerns about this auto assignment procedure. And I said to myself, well, tell me more about it. I would take the time out of my work schedule to sit down with these guys and listen to their concerns, and they seem to have valid concerns. A lot of their concerns were simply that, listen, a lot of times we get the sickest of the sick, right, in terms of populations. We get the end-stage renal diseases, we get the transplant cases, we get the hemophiliacs, we get the severe CHFs. We're the ones taking care of the severe cancer treatments. And so it becomes a concern for us because we're seeing the sickest of the sick. That's number one. 2, we're very unique in our group. And I said, how so? Well, we represent a large group of physicians who only contract specifically with the CCN and not so much with a lot of these health plans. And I said, okay, I respect that. And I think the third point they made as well was that we also don't get a huge chunk of what mix of what all the other health networks get. We don't get any of the OneCare patients at all. We get a very small percentage of the OneCare Connect patients as well. And so you really are leaving us with really members who really need the most care. And we're tired of also hearing that we don't coordinate care because we work with CalOptima for care coordination. We work with CalOptima for utilization review. So there's a screen when it comes to whether this patient could be transferred to a specialty or have a specific procedure. And so I spent tons of time listening to these concerns, and I respected those concerns. And I think they came to me in part because they felt comfortable expressing their concerns to me, and I think they felt even more comfortable knowing the position I am in, specifically in the structure of the board. And so I said, okay, I think it's fair for us to bring this up. And I'm glad we brought this up because I think it's important to have these conversations and these discussions. Because I think as a board, we want to do everything we can in our power to make sure members have access. And I thought about that word, and I talked to a couple board members about not this particular topic. I wanted to make sure we respected the law, but just in general when it came to member access. And one of the concerns and thoughts that came to my mind was member access is created by providers, right? And so for me, I sat back and I said to myself, what can I do to increase member access? Which means to me is increase the number of providers that sign up for CalOptima. Just like in Sacramento, the governor always talks about. That's why we created the HPEF, the Health Professions Education Foundation, is to put money into that foundation to recruit providers to work in low-income, underserved areas throughout the state. And it's the same story here in CalOptima. We simply wanted to increase access, so attracting providers. And if it seemed like we were seeing more and more providers who prefer CCN, based on some data and thoughts, then I thought it'd be appropriate to bring it up. Now, after talking with a lot of board members, and we're hearing a lot of these of our colleagues and people who represent health networks on my right, who I respect tremendously and have brought up different concerns, I think it'd be appropriate for us to maybe spend a little bit more time looking at the data behind CCN, specifically gauging whether we're really comparing apples and apples. And so I think later on today we're going to have some discussions, especially as we move on to item number 4, is looking at appropriately auditing and checking out the accounting and finances and see exactly, hey, listen, how much is CCN spending compared to our health network colleagues? How well is CCN doing when it comes to certain measures and taking into consideration risk stratifications, right? In fact, if we are seeing the sick of the sick, well, let's make sure that we're stratifying that appropriately to compare apples and apples with our colleagues in the health network. So even though I look forward to our discussions and dialogues today, especially among my colleagues, and especially among members of the audience and as well as executive staff, I think it might be a good idea just to maybe hold off until we finish this, hopefully, item number 4, and hopefully finish this auditing and assessment and figure out if there really is a unique perspective that the CCN presents. And if so, I think these points that are brought up by our colleagues in the CCN are absolutely valid. But I would simply leave you with the idea that at the end of the day, it really is about member access. And we know that, again, providers provide that access because that's the biggest struggle right now, right? Everybody has Obamacare under the ACA, but a lot of times people don't have access. And so we have to do everything we can to provide access. And we're not pushing for a single payer system, my friend, nor are we trying to jeopardize your business. And we want to make, in your livelihood, we understand we all need to take care of our families and our colleagues and so forth. At the end of the day, it really is about access and making sure that access is created by providers and making sure that we do everything we can to make sure members have access to providers. So with that, if my colleagues, as they continue to discuss this topic, Lee and Supervisor Doe and Alex and Michelle and everybody else who's amazing up here, as you guys are discussing this, keep in mind, maybe we need some extra time, as Ron would always say, is to really look at the data. And so let's spend some time and look at the data and go from there. But thank you for the opportunity to chit chat. I appreciate it.
Is that a motion to table the item? What's that?
December 6th. Well, it's a motion to table it until we get the report back from the account auditing and data from the quality measures, please.
Okay. So at the table until we have more data. Okay.
And I would say probably either December 6th, probably in January, I would say. But we'll have more discussions and I can make a better motion.
Mr. Hamblin, you had a comment real quick? No, that's...
Yes, just in terms of the timing. So I know we haven't got into number 2 yet, but part of that was the engagement of Milliman. And we're talking about the timing for this. They will have preliminary to us sometime in mid-December to late December. And once we go through it and look at it, we expect to have final sometime in mid-January, which would be in time to have it out for the February board meeting, just to give a timeline on that.
Mr. Chairman?
Okay. There's not a second just yet on this motion. Is there I'm
not seconding. I just want to.
Yeah. Let's take care of the parliamentary part first. So the motion was to table this until
we have February.
Or until, can we leave it more vague than that, until we have the more data?
Back from the Milliman stuff.
Okay. Is there a second on that?
Are we going to have a discussion?
Yeah, we'll have discussion after second, yeah. Okay, is a second by Supervisor Steele. Okay, discussion.
Yeah.
Mr. DeLuigi, you're first.
Mr. Chairman, and again, just to process, I think Dr. Katibi is correct. I mean, I do favor taking a look at data. I'm a little concerned that the case hasn't been made here, but I think that there's data and it needs to be looked at. I'm not really anxious to rush. I mean, because I'm thinking of the next item we have, which is talking about, I think, a pretty important assessment. And I think even per Dr. Katibi, if we're going to wait until we have the results of that effort, then let's just wait until that's done. Let's not put it for time certain. Just suggest that, Mr. Chairman, in terms of our process. We start putting time certain, then we're rushing to meet that, and we're getting all worked up if we're not there. And
yeah, so a friendly amendment until such time as you have sufficient data. Is that okay with the maker of the motion?
That's fine. I can bring it up, but that sounds great.
Okay. And then okay with the seconder as well? Okay, so friendly amendment to the motion until such time as we have sufficient data. Go ahead, Supervisor Doe, you're next.
I don't know how valid of a motion it would be just to put it over until we have sufficient data. I don't know how specific that is. The better way to go is probably just to take it off the agenda and then keep tabs on it. We're going to decide on item number 4. There will be an RFP. We'll get an opinion from staff how long the RFP is going to take and then how long that study will take. And then
is that a substitute motion just to table it?
I want to be deferential to the vice chair, but I'm just saying a motion to an indefinite date is kind of strange. I would say
The substitute motion right now is just to take this item off the calendar for agenda for this time.
Second.
Second. Motion second.
You have comments, Mr. Chair, if you don't mind.
Okay, go ahead with your comments. So we
Okay.
have a secondary motion to just to remove this from the agenda, and we have a second to that secondary motion. Go ahead and comments.
I'm going to make these comments even though the item's going to be continued until sometime in the future. I know it won't change people's mind and people won't get all mobilized again to accuse us of going to a single payer system, of upping, the cap on the auto assignment. But I just want to say it again. The whole point of us looking at this when you first posed the question, if we are doing the right thing, we should never be fearful of the answer. If what we're doing is the right thing, data will bear that out. We should never fear the answer of what we're going to find when we look into it. And that's why, what did we do when you asked the question, is we asked for an actuarial risk analysis by Milliman. Did we rush into it? No, we didn't. We asked for data so that we could compare apples to apples. Okay, so that's the first thing. And what did I say along the way, which is we'll look at the model and see maybe the cap should not be 10%. Remember I said that it could be maybe 5%, because if we find out that CCN is not the right way to go, I'm for lowering the cap. Because if CCN ends up costing us more money and it doesn't bring the kind of quality that we want, then we are in fact regressing. We're not progressing, right? Because now we're creating more of the single payer kind of in-house, running our own private IPA, okay, health network. And I don't want that. We're not in the business of running a health network. We're here to run a health plan, okay? So I'm for asking that question, and thank you for explaining the perspective of the CCN providers. Because I keep hearing people talking about how we're going to just do away with a cap, and I kept saying it over and over. And in fact, I even talked to doctors from the same plan who now come here and speak something completely different from what I said. And I even said it in writing, in text messages, in emails, and yet it is still misinterpreted somehow, and it's just annoying. And so when we come back in whatever, 3 months, 5 months, 6 months, please remember what I said today, and remember all of our thinking today, that we are looking at this from a data-driven perspective. Only that. I am not pushing. There are only a few of us out here who have no dogs in this fight, and I'm one of those people, okay? I'm not a doctor. I don't have a health plan. I don't have anything. All I care about is that we provide access and quality to our members. And here, I want to make sure, we have a members' health needs assessment that we spent, this board voted $750,000 to conduct. We reached out to 42,000 members in different circles, and 6,000 of whom decided to talk to us. 6,000. This is a sample population that's beyond reproach. Any person in academia would know a sample size of this magnitude is beyond statistical validity, okay? And what do they say? What do the conclusions say? That we need to have better access to primary care, okay? What does it also say in the area of mental health? 1/3 of the people who we survey say they don't know what services we provide. And another third said that because of stigma, they would never take advantage of our services. So therefore, we can sit here and say that we're the #1 plan in the world, and guess what? 2/3 of our members say themselves that they will not take advantage and do not know what we do. Okay, so before people talk about how perfect what we're doing is, I'm not saying we're not doing a bad job. We are the best in the state 5 years running. I get it. We can do better. That's all I'm saying, is let's look at the data and look at the way we do things in an objective, wide-eyed, clear mind, and see is anything we can do that's better. That's it, people. And frankly, this drama that I keep having to relive from time to time over, oh my God, we're going to create a single-payer system and we want to hoard members. I have no interest in that. We are a pass-through agency as far as I'm concerned. The CCN is just an effort to cater to a very limited group of members, right, who want that choice. And that's an accommodation. That's not a goal. And so we can change the accommodation if we see fit. So that's it. I applaud your proposal, and it would be interesting. I don't know if we will be able to know today, as far as number 4, how long it's going to take for that audit to complete. So that's why I think the better course of action is to take it off calendar and then reschedule and when we get the result.
Yeah, I agree with that completely. Other comments? Dr. Nguyen?
Yeah, I'm just going to keep this very simple. I think, Nikon brings up, ways in which he's trying to represent his constituency and optimizing and, really bettering where we're at. And I think Supervisor Doe was saying basically the same thing. I think we want to use evidence-based data. Balancing that with everybody in terms of the time that you guys put in terms of MAC and PAC and a lot of the community members today, I mean, from my perspective, I hear you. There was a reason, an arbitrary reason for putting the 10% cap. There was a concern, and the concern is very valid because, ultimately we are a partnership, and members are part of various, networks, and these networks need to be balanced, and there's a checks and balances, which is why I'm really happy that there's a lot of discussion, and unfortunately just a lot of emails that we've received, but I think it's very healthy. And coming from the members' perspective, so far, with my mom and with Choice, we don't really have concerns regarding member choice at this point. And so, I think it's going to be really, I trained as a physician, so I'm all about evidence and I'm all about objective data. The anecdotal data so far points to the fact that we should not lift it, and it'll be interesting to see in the months to come on how that pans out, and I'd be interested in being a part of that. So,
Mr. Penrose.
Thank you, Mr. Chair. I remember when the CCN was created, I voted for it. I'm a fan of the CCN. Conceptually, I think it's the right thing for us to do, and I said this, I think, at the last meeting, but if you go back and look at the reasons why we created the CCN, it was right at the dawn of Medicaid expansion. We knew that our numbers were going to grow. We knew that we would go perhaps to double the size, and we knew that access was an issue. So there very much is an access component of why the CCN exists in the first place. So I think to that degree, mission accomplished. That was a very different board at the time, but a lot of the participants in the discussion are here in the room today and were active at that time. And what I also remember was, and I'm a little bit surprised that this hasn't come up, at the time that the 10% cap was agreed upon or negotiated, it was also agreed that we would really do a fine job of looking in the mirror and putting the CCN under a spotlight. There were a lot of concerns that there would be an unfair advantage, that the CCN, if you think of it as one of many networks, that because it's run by CalOptima, that there would be unfair advantages both financially and in quality and otherwise, and with the auto assignment. And so as a compromise, we all agreed to this 10% cap. But we also agreed to really putting the CCN under a spotlight. A lot happened since that time. We've been through audits, we've been through several restructurings, we've been through a lot of things that I think distracted us from doing what maybe item 4 will help us to get to. But we, I think, collectively have not done a good job of really answering the question and doing it transparently. How is the CCN performing? How is continuity of care? How does the risk adjustment factor weigh in? There are some very, very sick members that are taken care of by the CCN network, and we all can embrace that. But how are we doing at it? The higher acuity comes with a need for better coordination. And so we better be doing a great job of care coordination as a CCN. And if we're not, we should call it out, as you're suggesting. Let's not run from it or hide from it, but let's really be transparent about it. I also want to sort of point out in all the correspondence and all of the discussion that's gone on in the few months, and Mr. Chair, you predicted that this would be a hot discussion. You were absolutely right. Our mission statement has come up a number of times, and I just want to be clear, because I've as many times as I've heard somebody reference the mission, I've heard them reference a component of it, and they get some of the words right, but I'm not sure that the intent is quite coming out. It almost feels like our mission statement is being used to justify the ends of an argument. So I wrote it down. And our mission statement, just to remind everybody, is to provide members with access to quality healthcare services delivered in a cost-effective and compassionate manner. So access is in there. What's not in there is maximizing physician participation. That's a phrase that's come out is our mission is to maximize physician participation. It's critical that we do so. We can't accomplish this mission without our physicians who we partner with. But our mission is not to maximize numbers of physicians who we're partnering with. Our mission is to do what I just read. I know we do that in partnership with our networks, all of them, including the CCN. The reason I jumped in to second your motion, Supervisor, or your substitute motion is, I think we'd be doing a disservice to ourselves and to this whole discussion if we table it to some date certain. Because what we're saying is we think that we should lift the cap after we get the data. But to your point, we don't know what the data is going to tell us. Maybe the data is going to tell us the CCN is our best performing network, and in which case I think it's a really valid discussion. We should lift the cap quickly. But maybe the data will show us that CCN really is 9 out of 12, and our new CMO has a lot of work to do. But again, I really want to embrace the notion of better together. And this discussion, as uncomfortable as it's been, has gotten everybody engaged. Our MAC and PAC met together. Congratulations. Thank you guys for doing that. That was a great report out, and it was a great process. And we listened to you. You did that at our request, and your conversation and your conclusions, even though we weren't all in the room, we listened carefully. So given that, I think it is a good idea to table it. I don't think that we should necessarily say this motion is, or this COBAR is coming back on some date certain, and then we're sort of right back where we started, or it's going to be everybody hold your breath for 4 months while we wait for this debate to resurface. Let's let the data speak to us. This is, Dr. Katibi's not going to let us forget that we might want to consider doing this. But let's let the data speak to us first and then act. So that's where I would weigh in.
Any other comments? Okay, we have a motion and a second to table this indefinitely. Is there anybody in opposition to doing that? Seeing none, that is tabled indefinitely. And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer to issue a request for proposal for consulting services to provide data analysis and to perform a market survey related to the CalOptima Provider Network Delivery System, and approve the related attached scope of work.
No, we have public comment on this issue too, correct? Go ahead.
Paul Cerroti.
Thank you again. Good afternoon, Dr. Yost and other members of the board. So this is our opinion as a independent physician or practitioner. In the light of transition of the whole child model to CalOptima, it may not be the best time to conduct a study given the concerns we have about limited staff resources. It is crucial that the implementation meet the timeline of January 1st, 2019. We certainly would not want to negatively impact the children in this program. This proposal does not specifically define the purpose and the cost of completing the survey. But if the board approves hiring a consultant to analyze the networks, it would only make sense to create an apples-to-apples comparison of CCN and health networks based on quality and performance metrics. The metrics defined in the attachment to the report item should be carefully reviewed and approved by the advisory committees to the board and the health networks. And thank you very much.
Thank you.
Bill Barcelona?
Good afternoon. Bill Barcelona with America's Physician Groups. Thank you for the opportunity to comment publicly on item number 4. America's Physician Groups and our members welcome transparency. We welcome comparative studies. We appreciate that this board is so actively engaged in how to make sure that the right level of care is delivered to the members of this health plan, and thank you for that. Just a few things. One is CalOptima, I believe, is a board member of the Integrated Healthcare Association, and the IHA has been studying the performance of different networks across California, and its Atlas II effort has made that data publicly available through the Office of the Patient Advocate and on its own website. The data involves Medicaid managed care, Medicare Advantage, and commercial HMO and PPO from 2013 and 2015. And later this fall, it will release the 2017 data as well. And we've been very pleased to see in the recent analyses provided by Dr. Rideout at the IHA that as the risk curve increases, as providers are brought into alignment with the objectives of the health plan as a payer to accept risk, quality, documented quality increases, cost on a per capita member basis decreases, and out-of-pocket cost to individual Californians decreases. Most recently, Dr. Rideout presented some information in Sacramento 2 weeks ago before a health affairs panel that showed that it's a 3-to-1 spread in terms of full risk delivery systems providing care at a higher quality level with only $188 per annum out-of-pocket costs, and in a fragmented network, $880 per annum. So I commend those studies to you as you move forward, and thank you for your concerns. I would like to also acknowledge the discussion earlier today during Michael's comments about the seriousness of the risk regulation. We are very, very concerned about this regulation. We believe that it will prevent our members from contracting with CalOptima because CalOptima is not a fully licensed Knox-Keene health plan. And so we have some materials. We'd be happy to share them with staff as we move forward on this, and we thank you for your comments and your concerns. Thank you very much.
Thank you.
Reginald Abraham?
Not quite sure what else to say since you tabled the last commentary, but I will say this: I'm a little dissuaded but encouraged by the debate. You know, when you use words like dramatic, and you're tired of hearing that this has come up again, it means there's truly a concern. And we are the constituents. We, the patients, the providers. And my friend, if indeed you take more and increase this 10% to 20, 30, 40, you have the, well, you can mutter, but talk to me if you want to.
Wait, please, just direct your comments through the chair to the board as a whole.
Something was being said to me, so I responded.
As public comment, just respond and make your comments to the board
please.
As a whole.
Thank you.
Please, thank you.
Thank you. So to that end, if it's 20, 30, 40%, you're going to end up with a de facto single-payer network. If it walks like a duck, talks like a duck, acts like a duck, it is a duck. I'd also ask the members to make sure that we have data that's collected that's meaningful. If I were to tell you that of all the surveys done, people who drank sports drinks have the highest degree of orthopedic injuries versus people who don't drink sports drinks, what would you take away from that? Sports drinks cause orthopedic injuries? Obviously not. It's just that those people are probably more engaged in activities and hence probably are more likely to get injured and hurt. So the data is important. Garbage in is garbage out. So I'm not quite sure where you're engaging your data from and what you're engaging it from. I would encourage you to please engage the IPAs that are out there so that we get a fair and balanced view of what is being investigated. Thank you.
Thank you for your comments.
That's it.
Okay, that's it. All right. Okay. We have item board member comments or a motion.
Mr. Chairman, just one thought, maybe more than one thought, but I really appreciate on both of these items the opportunity to hear from as many folks who are engaged and involved in the system and are players in the system as we can. So the idea of having the MAC and the PAC carry out the role that this board has given them, and the other voices we've heard today, again, all very, very important, and I have no doubt that anytime we agendize a question along the lines of what we just did, we're going to get that, and that's appropriate. But I think to the question of purpose for this item, I think Supervisor Doe, his comments spoke very directly to what the purpose of this study is. I think Director Penrose raised some additional comments. Again, this is CalOptima. This is us. This is the governance of this organization. Despite how well we're doing, we're not going to rest on our laurels. There's, the whole scene, the whole environment in healthcare is extremely fluid. And it's our interest and our intent to be able to stop and take a look at ourselves and to do this periodically. Hasn't been done for quite a while. Not that I should have to defend any periodicity. That's up to us, because again, it's us looking in the mirror and determining, are we the best we believe we can be? And what else is out there? Let's keep an eye on that. And let's always bring that into play. And my intent would be that this study be a broad-ranging gathering of some very important data. I really appreciate the data that Mr. Barcelona raised. I think that very definitely fits within the context, and I'm sure that Michael and the staff probably have intent to include that sort of information in it. The other thing I would say is, again, as I look at this, at the scope of work, I think it's very comprehensive, and that's commendable, and I think it gives us a chance to gather the quality of the data. So, again, that's the purpose. I think there's a very, very important purpose. No organization worth their salt avoids taking the kind of look that we're talking about periodically. And I think that's what we have to do, and that's what we would like to do. But in looking at this scope of work, I was looking at it, and I'm pretty impressed with the range of it. The one thing that occurred to me, though, is, again, getting as broad a perspective on what is successful out there, what we're seeing prove very successful. For us, California is very important. For those of us who've been around a while, we recognize California is a different animal, and so we really do have to hone in on the California scene and make sure we have a clear sense of it. And we're unique from other states, too, in terms of how the environment is. But I don't want to ignore what else is going on out there in the universe, across the country. So I'm talking about, getting some clear recommendations from any consultant on what they're finding out there that they believe we should be taking consideration of and assessment of as we make some of the kinds of decisions that we'll make prospectively on our network, on our system. So to the extent that there are other directions, if there are pilot projects, if there are other studies, again, as were mentioned, and other successful models of integrated managed care delivery systems and having success, again, throughout the country, I'd like to see those included. I want to make sure that this scope of work doesn't preclude that sort of an extensive look.
Mr. Penrose, you're next.
Thank you, Mr. Chair. I again appreciate the comments of the MAC and PAC, the time that they spent on this item as well as the previous one. One thing that they pointed out that really resonated with me was the scope and the fear of the cost of this. And of course, one of the answers to that is we won't know the cost until we do an RFP, and that's what this approving this would allow us to do. I took a look again at the statement of work that's proposed, and there are a number of things on there that I feel could be going beyond even what our discussions have been the last few months. And I tried to really look at the items that really hit the heart of what our discussions have been. And to me, the two that really jumped out were numbers 4, which is kind of a small one, but it definitely, that topic had come up, and number 7, which really hits to the heart of what we've been talking about, comparing the networks, including the CCN, from a performance basis. As one of our speakers just now pointed out, let's make sure that you're looking at the right data. So making sure that we bring in an expert that's going to allow us to really do the right comparisons, looking for cause and effect and things like that. So without going through all of the items on there, and Supervisor, this is your item. I don't want to cut out something that might be really important to you, but I wanted to suggest that maybe if we start with 4 and 7, maybe there are 1 or 2 others. Could we consider that a phase 1? And then number 1, we'd probably get the report back more quickly. We'd probably keep the cost down, and I think we could ease some concerns at the same time.
Just for the public people following along, item 4 of the scope of work has to do with what are the minimum numbers that a network needs to have in order to function adequately, and item 7 refers to developing network performance evaluation tool and report card.
Well,
go ahead. This is for clarification. Go ahead, Supervisor Doe. Go ahead.
When I made this proposal a couple of meetings back, yes, the discussion started with the question of what number should we use to set the threshold at. It was 10,000 was proposed by staff, and then some mentioned that historically it was 5,000, and we went back and looked, and it was in fact 5,000. But of course, that was established back in the 90s, right? In terms of number of years, for those of us up here, it's not that many, but in the healthcare system, that's eons ago. It was set, the 10% cap for CCN was also set back at that time. And so these are all legitimate questions like, okay, can we update this? Can we make it current? So when I posed the question, I also had in mind, again, the member needs assessment report that I held up earlier. And I'm going to read off some of the concerns that they raised. I already mentioned 2 before, which is there was a complaint, somewhat of a concern over access to primary care. And then in mental health, we really have not reached over 2/3 of our members. But in the traditional physical health area, which we take great pride in being the #1 plan in the state. Now, mind you, again, this is the first and only comprehensive community outreach that we have done, going into homeless shelters, poor neighborhoods, community centers, places that we wouldn't necessarily go on a regular basis to talk to. And we also did not rely on the traditional survey, fill out the form thing, because as you know, in an ethnic community, there's a reluctance to providing information in writing to the government, right? And then you have a lot of barriers to participating in the survey process to begin with. So we got this data from engaging people directly in focus groups, small community forums. And on physical health, the concerns were that it is very difficult to navigate the healthcare system. The long wait time to get appointments, hours of operation. Patients, you know, they have to work long hours and they can't get to it, especially on the weekends. Lack of transportation to go to the doctor. And then a big one is cultural competency in our providers. Now, these are factors that go into the actual performance of our mission. And these are raised in our own survey. And so I feel like this is the right time for us to look at all of our delivery system, more than just the number. And I mentioned before, we may find that 5,000 and 10,000 are too low. It could be that the study will say the optimal minimal number should be 20,000, should be 30,000. I'm agnostic, I don't know. That's what the study, the audit is going to tell us. It's compared to other systems around the state. Just like I said, that the 10% on the cap, it could be 10%, it could be 5%, or it could be 20%. Some speakers focus only on the upside and they never focus on what I said about the downside, conveniently. But in terms of this, I'm reluctant to narrow the scope of the RFP just because why would we ever want to have partial information? I would rather wait an extra month or two and get all the data. And then between that and our, the Milliman study to come back, we have all the data, and at that point we can decide. So I do have a question for Director Luigi, because I think you brought up a good point, but I wasn't clear. What would you add to the proposed, the attachment 1, the scope of work? What would you add there? You mentioned something about comparing to other systems, other health networks.
Again, I think that I'm talking about making sure that our consultant does take a broad perspective nationally.
National, okay.
Yeah. And again, with the recognition that we all know that California is different, and let's gather information. But Michael, I don't, no pride of authorship on those words. If you've got some other thought about how you want to construct a particular additional item in the scope of work to achieve that.
Right, so compare ourselves to some other models nationally is what you're talking about.
Yeah, I mean, sure. You know, there's efforts,
that's,
you know.
And I have another addition myself, Michael, is we should also add the members' needs assessment study that we did. I mean, we spent so much time on it that it should be added to this scope of work. So that way, when they do the study, that they can use some of the information that we already have as well. Please. That's it. Thank you.
Okay. Mr. Schoeffel, Director Schoeffel.
Yeah, thank you, Mr. Chair. I'm just thinking there might be one, or at least one more reason why we'd want a more thorough examination of the data. And maybe I'm connecting these things inappropriately, but it's just trying to live in the future while you're living somewhat in the present. And that is that depending on how the regulation goes at the Department of Managed Healthcare, this data might be very useful in terms of formulating a position, taking a position with the regulator, being able to come up with the optimal plan of action, as Supervisor Doe said earlier, that's based on evidence as opposed to we need to resist this because it's a burden, a cost burden, a time burden, and everything else. If we actually had some evidence that we could examine, look at the pros and the cons of it, it would, I think, could be very helpful in formulating what might be a policy that we need to take to those hearings sooner than we might like to, and may not have that much time to actually make our case. That's my supposition, but I think that would be a pretty good reason to get as thorough a report as we possibly could.
Just a clarification, are you thinking in terms of quality reports, like in terms of item 7, developing a network performance evaluation tool? Are you thinking, what are you specifically thinking in terms of this particular report, adding data or information for which we can use to testify about any proposed DMHC regulation?
I would just say have as thorough and comprehensive a report as we could on all of these items.
It's my item. Let me make the motion so that we're clear on what we're discussing, Mr. Chair.
Sure, go ahead.
So my motion would be to move the recommended action using the categories defined in attachment 1. Currently there are 11 categories, with the 2 additional ones that we mentioned today from the Director DeLuigi, comparing our model to other models nationally, and also to attach the members' health needs assessment report. So that would make it 13 categories of information included in this audit.
Or you could expand item 8, which includes the Southern California. You can just expand that to regional or to national, but that's fine. However you want to set it up is fine. Is there a second by Katibi? Further discussion from the board? Go ahead.
I think that's better than having 13 on the day after Halloween, so good call. Maybe just some clarifications then. So a few examples of things in the statement of work, and I apologize to the public if you don't have this, but I'll try to be clear about what I'm referencing. Number 1 is doing essentially risk adjustment, exploring actuarial methodologies to risk adjust revenues and medical expenses across health network. Really important. I think we already have a consultant that's doing that. So I wonder why it needs to be on this statement of work. The MLR number 2.
Wait, Mike, go ahead. Wait.
Be on the statement of work for the consultant, because Milliman is already doing it.
Milliman is already doing that, okay.
So that would bring us down to 11.
Okay. All right. Will that be?
Well, let me just ask it as one comprehensive question. I think Supervisor probably would want to respond. Number 2 is perform an MLR comparative analysis, which I think we've already done. Maybe the intent is to include the information from that in the review from the consultant. Number 6, survey and verify payment methodologies used by health networks. That can go a lot of different directions. If you think of the number of payments that are made from health networks to providers, I think if we want to leave that one on there, I think we would need to be a little more clear about what we're looking for. Are we looking for, are our networks paying fee for service versus capitation or some other method? Or I don't think what we mean is let's go in and audit every payment and you look at rates and who's paying what rates compared to each other. That I think would start to get into competitive issues between networks that we may not want to open that can of worms. So those are 3 that jump out at me that I would wonder if we could take them out.
What would you suggest, Lee, for number 6?
I'm not sure if it's relevant. I'm not sure if it's relevant. I think we're looking for how our overall network is performing. We're looking for how our individual networks are performing compared to each other. I think we could have a cause and effect issue, as one of the speakers brought up earlier. If we try to say one network is using capitation more than another and they have good outcomes or not, and therefore start to make some conclusions. So I'm just sort of confused about what the intent of that one is. I would leave it out.
And I want other board members to jump in. I think the intentions are to see if there are certain incentive organizations financially that might necessarily provide better performance from one health network to another. So I think it's more of a learning tool, I think, to figure that out. That's one. Two, I think it would always also look to see how maybe some health networks are looking at, again, increasing access through certain types of methodologies. But I think, I don't know, I think it's pretty fair to keep it, but I'd like to see what other people have to say. Yeah.
Other board member comments?
Chairman, I think I
All
was
right,
going
go
to
ahead, Mr. DiLuigi. Go ahead. You're next.
Question to Mr. Penrose. I think as I'm looking at number 1 and 2, because I'm looking at this attachment as kind of a scope of work for everybody involved. So as the matrix indicates, it's CalOptima.
Is it possible to project the scope of work for the audience from our IT people? Part of that. Yeah, is it possible for our IT people to project the scope of work, the attachment 1 to item number 4? You don't have it? Okay, all right.
Well, at any rate, what I was going to say is the way the attachment lays now, I think it's consistent with what Mr. Penrose indicated he was assuming, and that is that under number 2, performing the MLR comparison analysis, that CalOptima is engaged in that and will utilize that. For number 1, you do have an existing consultant. You'd utilize what they're doing. Have I got that right?
So we did an MLR audit of the health networks, but we couldn't do it of the community network without the risk assessment. So if we get the risk assessment done, we can do an MLR audit of the community networks, my understanding.
And you are correct in that the way the grid was created was CalOptima, existing consultant, new consultant. So the RFP would only be, at this point, for the items checked under the new consultant, not under existing consultant or not under CalOptima.
Yeah, so item number 1 and item number 2 are already being done, so would not be as part of that. And same with
no, they'd stay part of the scope of work. It just wouldn't be part of the RFP for the consultant.
Right. Yeah.
Yes.
So, go ahead, you want to repeat your motion?
Keep my motion to include number 6 as well.
Mm-hmm. Okay, we have a motion and a second. And then, keep in mind our MAC and PAC that we had to meet did recommend unanimously that we not approve this item. Just thought I'd make sure I threw that out there for everybody. All right, Mr. Nguyen. Dr. Nguyen. Sorry, Dr. Nguyen.
Mister's fine. I never get called Mister, so I'm happy with that. I'm down for a more inclusive. I don't mind including 6. I'm pretty ambivalent about it. More the merrier. We can always come up with conclusions later about that. I think the big thing is including COES plans as well, including all the Northern California COES plans as part of our survey. I mean, we talk about nationally, as Ron had mentioned, but I think it's very important to compare ourselves to even smaller COES plans, SenCal, San Mateo. How are they doing things? Because at the end of the day, they have a very similar county organized health system, and I think that's where we should look first before determining more things. And nationally is great, but let's look at ourselves regionally and statewide and go from there. So if there's a way to add on to that as a focus to be able to add on to Ron's point, Supervisor Doe is happy to, I don't know if you'd be happy to add that on to your motion to take a closer look at COES plans and then, nationally too.
That would be fine, yes. Amendment accepted.
We're, just from a procedural, we're going to get an RFP back, so we'll actually get a cost determination as to what this is going to be that will have to be approved by subsequent board action. That's correct?
Yes, it is.
Yeah, I don't know. Any other comments from other board members? Do a motion a second. I don't know. Been on the CalOptima board for a long time, and both in the past and currently, and I'm concerned on a number of levels with doing this. I'm all in favor of more information. I think the more the better. But I'm also very conscious about cost. I mean, I think you can get all kinds of information, but our primary goal is to provide high quality, cost-effective care, provided in a compassionate manner for our members. and I'm not sure we want to direct payments from doing that to doing something else. So I do agree that, especially in this healthcare environment, that if you're not growing, you're dying. You do have to continually evolve. You do have to continually improve yourself. We do have a lot of items on the agenda, especially with the whole child model and the CCS patients, the sickest patients that we have to take care of and are going to be rolled into our system. And that's going to be incredibly challenging. So I mean, it's nice to come up with a great big wish list. But we will bring this back for an RFP, and I just want to make sure that we're all comfortable with the cost and what the benefit of that cost is going to be when it comes back. We'll take a look at that. But we have a motion and a second. More discussion.
I'm sorry, just one more comment. I just to clarify where my vote's going to go, I am going to be opposed to this item because of the scope. And I don't want that to create confusion from my previous comments. I think it's great for us to look in the mirror. I think the spirit of where this is going is well intended. I just think the scope's too big, and maybe we'll have another opportunity to discuss that.
So we have a motion second. Any further comment or discussion from board members? Okay. All those in favor of going forward and getting an RFP to see what this costs, please. Actually, I think I want to do this individually. It may be a close vote. I guess raise your hand if you're voting yes. Okay, so we have Supervisor Steele, Mr. DeLuigi, Ms. Berger, Dr. Nguyen, Dr. Katibi, Director Schoeffel, and Director Doe, all in favor. And all those voting no? Mr. Penrose and Dr. Yost voting no. So the item does pass. And Madam Clerk, would you please read the next item?
Authorize the following actions related to the requirement that all contracted providers be enrolled in the Medi-Cal program through the Department of Healthcare Services by January 1st, 2019. Authorize CalOptima to continue to contract with non-Medi-Cal enrolled providers through June 30th, 2019, subject to CalOptima's receipt of proof that each provider's application to the state to become enrolled in the Medi-Cal program was submitted to the DHCS prior to January 1st, 2019. And authorize letters of agreement with non-Medi-Cal enrolled specialist providers identified by the Chief Medical Officer through June 31st, 2019, as required for access to services or continuity of care.
Michelle, do you have a brief report?
Good afternoon, Chair Yost and members of the board. So this item has to do with the requirement that providers become Medi-Cal enrolled, and staff is making two recommendations. First, that the board authorize staff to maintain those contracts with providers who get their Medi-Cal enrollment in by December 31st. Also, that we would be able to provide access to critical specialty services through LOAs with non-enrolled providers on a case-by-case basis to address continuity of care issues and access issues. Any questions about this item?
Any comments from board members? And just
the only thing I would say is, again, I mean, this is, our direction is clear. We're going to move forward, and we've got work to do on it. But this is one that has that is potentially dire for us when you think about it. You think about the significance of it. And I think we're heading in the right direction. I have no quarrel at all with any of the recommended direction. I think that makes sense. We're being very practical. But we're going to have to, this is another one we're going to have to watch very close in terms of how this is being played out. It sounds to me like you're monitoring the state scene pretty closely, and in all likelihood we'll get some initial recognition and collaboration out of the state in terms of some of the things that we believe we need to do. But I think that this is one that would be good for us to have a pretty clear sense of too. Because as I look at it, and you don't have to answer the numbers now, but it looks to me like we've got pretty significant numbers. And then the question becomes, well, how many of them, in fact, complete all their documentation and, in fact, get it in on time? So then that tells us what's left, but we still don't know how those are going to go. So just a reinforcement of that.
I have some preliminary numbers for you if you'd like to.
Yeah, go ahead. And also, do you have an estimation of what the backlog is for getting Medi-Cal certification through the state?
Absolutely. So right now, we don't know exactly the numbers of providers that are submitting applications, but we know it's significant across the state. And all of the health plans are concerned about the impact for access to care for Medi-Cal enrollees. As far as the backlog, some of the applications are taking up to 6 months. And it depends on if they're an ORP provider, which is an ordering referring provider, or if they're actually Medicaid enrolled provider. So there's two types that we're looking at. And the enrollment process itself is fairly daunting for the providers, and it does cost money. So most of the providers have to pay over $500 to enroll through the program. There's, right now, when we look at the numbers, of the PCPs, and this is really our strategic goal right now, is to make sure that member access to their PCPs doesn't change. Of the 26,000 lives that we're looking at, with your approval of this measure, what happens is that we take it from 118 PCPs, affecting about 26,000 lives, down to only 12 that are going to be missing, not having applied at this point, and we expect to have those in by December 31st. So it would reduce it from 26,000 members impacted to 400 members impacted if those 12 providers don't get their Medi-Cal enrollment in on time. As far as the specialist, that's a little bit more challenging for us, but we have some cross-functional work groups working on this on a bi-weekly basis, actually twice a week, not every other week. So we're working diligently to make sure that we can bring back any other recommendations as required to lessen the impact on our members.
Other comments? Okay. Mr. Penrose.
Yeah, I assume our networks are engaged with us in this effort.
Absolutely.
They're equally at risk. This is significant. I would just ask, assuming this item passes, for at least monthly updates to the board of those statistics are really helpful, and we could have a crisis on our hands.
I'll take a motion to approve.
So moved.
Moved by Dr. Nguyen, second by Dr. Katibi. All those in favor say aye. Aye. Any opposed? Seeing none, that passes.
Thank you.
Dr. Katibi would run down any of the CCN docs that aren't.
I will personally.
Madam Clerk, would you please read the next item?
Authorize modification of CalOptima Medi-Cal Policy FF 1005C, Special Payments, High Cost Exclusion Items as follows. Eliminate previous carve-out for services paid under the California Children's Services Program. Implement a new procedure to require the submission of a remittance advice for qualifying services provided for PHC and HMO members, and clarify that such payments are paid to a contracted hospital for qualifying outpatient services and qualifying inpatient services paid on a per diem basis.
Mr. Do you have a quick report for us?
Yeah, I'll keep it fairly brief. Good afternoon, Chair Yost and members of the board. This is really a refinement of a longstanding CalOptima policy on making supplemental payments to hospitals to cover the costs of certain high-cost items, such as implantable devices, high-cost pharmaceuticals, orthotics, and prosthetics. So there is a comprehensive list that is included. So there are essentially three major changes to this policy. The first one is to prepare for whole child model. Currently, this policy excludes paying for CCS covered conditions. We obviously need to change that to be ready for whole child model. The second change is we want to implement a new procedure to verify that we are not making any double payments, especially for members assigned to HMOs and PHC assigned members. And the final change is really providing clarification on when supplemental payments are available for qualifying inpatient and outpatient services, exactly as referenced in the recommended action. So I'm happy to answer any questions regarding any of the three changes.
I'll move the item.
Okay, moved by Director Penrose, second by Director Schoeffel. All those in.
I just have a quick comment. I think
sure,
this is absolutely. I think it's appropriate, obviously, because these are very costly things, and so I think this is just a great example of, again, I think it's a great partnership between our health networks and CalOptima, but how, again, risk stratification and how we decided to take out the more expensive, costly services under our wing, right? So I want to say I appreciate that, and I want to make sure we do that. But these are great compromises we do for our health network partners. Thank you so much.
All those in favor say aye. Aye. Any opposed? Seeing none, that passes. Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer, with the assistance of legal counsel, to enter into an amendment to the coordination and provision of public health care services contract with Orange County Healthcare Agency to extend the contract for 5 years through December 31st, 2023, and update contract language to address programmatic and regulatory changes as summarized.
And for the record, Director Sanchez is not participating in this item due to his position at the Orange County Healthcare Agency and will leave the room during the discussion and vote. And Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other abstentions or recusals? Okay, seeing none. Do I have a motion?
So moved.
So moved by Mr. DeLuigi, second by Dr. Katibi. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer, with the assistance of legal counsel, to amend and extend the physician medical group contracts with Ultimed Health Services, AMV Prospect Medical Group, DaVita Medical Group, Arta Western California, DaVita Medical Group, Talbot, California, Family Choice Medical Group, Monarch Healthcare, Noble Community Medical Associates, and United Care Medical Group, One Care Shared Risk Physician Medical Group contracts to extend these agreements for the period January 1, 2019 through December 31st, 2019.
And for the record, Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other recusals? And Supervisor
Chairman,
Steele?
I'm not participating from number 8 through 11.
8 through 11. Okay, thank you. And that's Supervisor Steele. I'll take a motion to approve.
Moved.
Okay, moved by Director DeLuigi, second by Director Berger. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer, with the assistance of legal counsel, to extend and amend the One Care Connect Health Network contracts with Ultimed Health Services, AMV Care Health Network, DaVita Medical Group, Arta Western California, DaVita Medical Group, Talbot, California, Family Choice Medical Group, Fountain Valley Regional Hospital and Medical Center, Heritage Provider Network, Monarch Health Plan, Noble Community Medical Associates, Prospect Health Plan, and United Care Medical Group to exercise CalOptima's option to extend these agreements through December 31st, 2019, and any necessary language provisions required based on the three-way CalMediConnect contract between CalOptima, the California Department of Healthcare Services, and the Centers for Medicare and Medicaid Services, and other statutory, regulatory, or contractual requirements.
For the record, Supervisor Steele is not participating in the discussion and vote in this item due to potential conflicts of interest under the Levine Act, and Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Any other recusals? Seeing none, are there questions? I'll take a motion to approve. Moved by Supervisor Doe, second by Dr. Katibi. All those in favor say aye. Any opposed? Seeing none, that passes. And agenda items 10 through 15 involve contract amendments related to enhancements to provider rates related to Proposition 56 of tobacco funds. And these items are agendized separately to address potential board conflicts of interest and to try to make sure we maintain a quorum. Item 10, Madam Clerk, would you please read the item?
Authorize the Chief Executive Officer to enter into contract amendments of the Medi-Cal Health Network contracts with the assistance of legal counsel for Ultimed Health Services, AMV Care Health Network, Chalk Physicians Network, Children's Hospital of Orange County, DaVita Medical Group, Arta Western California, DaVita Medical Group, Talbot, California, Family Choice Medical Group, Fountain Valley Regional Hospital and Medical Center, Heritage Provider Network, Kaiser Foundation Health Plan, Monarch Health Plan, Noble Community Medical Associates, Prospect Health Plan, and United Care Medical Group to continue to pay individual providers Proposition 56 appropriated funds and to compensate the health networks an administrative fee for performance of these responsibilities for services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and the changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
And just for the record, due to my affiliation as a physician anesthesiologist at CHOC, I will not be participating in the discussion nor vote on this item, and I'll turn the gavel over to Dr. Khatibi.
Thank you. Madam Clerk, for the record, also note that Supervisor Steele is not participating in the discussion and vote on this item due to potential conflicts of interest under the Levine Act. Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other recusals? Seeing none.
The recommended item.
So moved. Director Luigi, is there a second? Second, Supervisor Doe. All in favor, say aye.
Aye.
Any opposed? Motion carried. Madam Clerk, could you please read the item?
Authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network physician contracts, except those associated with St. Joseph Health and the University of California, Irvine, to continue Proposition 56 payments for eligible services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and the changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
Thank you, Madam Clerk. For the record, Director Schofel is not participating in this item due to possible conflicts of interest and will leave the room during the discussion and vote. Both Supervisor Steele and Doe are not participating in the discussions and vote on this item due to potential conflicts of interest under the Levine Act. Are there any other recusals? Any questions for staff?
Move the recommended action.
Moved by Director Luigi. Is there a second?
Second.
Second by Director Penrose. All those in favor say aye.
Aye.
All opposed? Motion carried. Madam Clerk, would you please read item number 12?
Authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network specialist physician contracts associated with St. Joseph Health to continue Proposition 56 payments for eligible services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
Thank you, Madam Clerk. For the record, also note that Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussions. Director Penrose is not participating in this item due to its association with St. Joseph's Health. And Supervisor Doe is not participating in this discussion and vote on this item due to potential conflicts of interest under the Levine Act. Are there any other recusals? Seeing none, are there any questions for staff on this item?
Excuse me, Mr. Chair. Note also for the record that Chair Yost is not participating in this item.
Correct. Thank you. Noted. May I have a motion?
So moved.
Moved by Director Nguyen, second by Director Berger. All those in favor say aye. Aye. Any opposed? Motion carried. Madam Clerk, would you please read item number 13?
Authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network primary care provider contracts associated with St. Joseph Health to continue Proposition 56 payments for eligible services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and the changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
Thank you, Madam Clerk. For the record, please note Director Schofel is not participating in this item due to potential conflicts of interest Director Deluigi is not participating in the discussion and vote on this item due to his associations with St. Jude Clinic. Director Penrose is not participating in this item due to his association with St. Joseph's Health. Supervisor Doe is not participating in this discussion and vote due to potential conflicts of interest in the Levine Act. Are there any other abstentions or recusals? Are there any questions for staff on this item?
Chairman, just informational. I mean, my recusal is not based on conflict of interest under the Political Reform Act, but it is under remote interest given my volunteer service on the clinic board, and so I'm not gonna participate or vote in the item. I don't have to leave the room, and that's true for both item 13 and 14.
Thank you for the clarification. Please noted. Any questions for the staff on this item? May I have a motion, please?
Moved.
So moved by Director Nguyen, seconded by Director Berger. All those in favor say aye.
Aye.
All opposed? Any opposed? Motion carried. Thank you.
And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer, with the assistance of legal counsel, to amend CalOptima Community Network mental health provider contracts associated with St. Joseph Health to continue Proposition 56 payments for eligible services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
And for the record, Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Director DeLuigi, who gave us previous clarification, is not participating in the discussion due to his association with the St. Jude Clinic. And Director Penrose is not participating in this item due to his association with St. Joseph Health and will leave the room during the discussion and vote. Any other recusals? Okay, seeing none, I'll take a motion to approve. Moved by Supervisor Doe, second by Director Berger. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer, with the assistance of legal counsel, to amend CalOptima Community Network provider contracts associated with the University of California, Irvine to continue Proposition 56 payments for eligible services rendered in state fiscal year 2018-19 and for future extensions as long as the state of California continues the Prop 56 increase payments to CalOptima, which may be subject to board approval and the changes to the program as necessary and appropriate to comply with the law and regulatory guidance.
Okay. Thank you. And for the record, Supervisor Doe is not participating in this item in this discussion and vote due to potential conflicts of interest under the Levine Act. Directors Nguyen and Schofel are not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Any other abstentions or recusals? Seeing none, I'll take a motion to approve. So moved by Dr. Katibi, second by Director DeLuigi. All those in favor say aye.
Aye.
Aye. Any opposed? Seeing none, that passes. Madam Clerk, would you please read the next item?
Authorize reallocation of budgeted but unused funds of $675,000 from capital hardware and software to capital professional fees to fund the CalOptima Provider Portal project through June 30th, 2019.
Okay. And Len, do you want to briefly introduce this item?
Sure. This is primarily a budget reallocation, but if there's interest, I can certainly go into a little history and background about the portal.
Depth that didn't get that in during their briefings? Okay. See none? Okay. Question from Supervisor Steele. Go ahead.
It's not the question. You know, when government agencies want to do internally all these IT stuffs, first, sometimes that it doesn't work or sometimes it costs more. I support this item because there's no adding more money to this project, but I suggest that we maybe create the ad hoc committee to look over or work together with the staff, or second, that staff comes back every month and try to give us the process that, you know, what's been done and what's going to do, because it's very important. I see a lot of agencies that, you know, ended up ruining it or ended up like, you know, not working, and it ended up costing so much.
What do you propose in terms of an ad hoc with the direction to the
Work-
ad hoc?
Working together and look at the process, or that just staff coming back every month to report us that, what was the process for that month.
And, an ad hoc normally has a set goal and a set time. If this is, are you thinking this is going to be something that would happen indefinitely?
Until it's done, because there's about $675,000 cost. So maybe that, we can create ad hoc if that is costing more than what they are, moving from the budget that they're, or that they just come back and, I really have a problem with the agencies that they try to do something like IT programs that they try to do internally, because I see so many times that it was not really working. So we want to really look over that what is going to be done.
Okay. Can we?
Chair Yost,
yes.
just a possible suggestion. I do it's not monthly, but I do a quarterly report to the Finance and Audit Committee about some other.
How long it's going to take, though?
Pardon me?
How long it's going to take?
Oh, the first phase will be completed by December 2019. So that would be at least 4 or 5 updates.
So you can come back in December that when it's done, right?
Sure.
So that cost is going to be not more than $600,000. I'm looking at the number here.
That's actually just the reallocation. It's $1,050,000 for the total project. Yeah.
Right, but you are moving that. So.
Need the FAQ quarterly if that's appropriate.
Okay. Or maybe Supervisor Steele, maybe you and I can talk offline a little bit and come back with a proposal for the next meeting and try to identify how we can make this work, because I'm open to doing whatever the board wants to do.
Fine.
Okay, is that cool? Okay, all right. We have a motion and a second. All those in favor, say aye. Aye. Oh, yeah. Oh, sorry. Maybe I don't have a motion second. Let me take a motion first. Moved by Director Luigi, second by Director Berger. I got a weird look from our clerk of the board. Now that we have a motion and a second, all those in favor say aye. Aye. Any opposed? Seeing none, that passes. Madam Clerk, would you please read the next item? Sorry about that.
Ratify revised Amendment 33 of the primary agreement between CalOptima and the Department of Healthcare Services.
Okay. And Michael, as I understand, this item involves a revised Department of DHCS contract amendment and retroactively extends existing adult expansion MLR by 1 year, but has no fiscal impact. Is that correct? Okay, I'll take a motion. Is there any questions of staff? Take a motion to approve. By Dr. Katibi, second by Director Berger. All those in favor say aye.
Aye.
Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize and direct the chairman of the Board of Directors to execute Amendment A6 to the PACE agreement between the Department of Healthcare Services and CalOptima to extend the agreement through December 31st, 2019.
And Michael, this is just involves a contract extension, correct, with DHCS? Okay. Are there any questions of staff? Take a motion to approve.
So moved.
Moved by Director Penrose, second. Second by Dr. Nguyen. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. And item 19, would you please read the next item?
Authorize the Chief Executive Officer to participate in the Be Well Orange County Initiative by facilitating discussions regarding one or more of the proposed result areas and to assess the feasibility of CalOptima's participation with the Orange County Healthcare Agency and various hospital systems in support of the Be Well Orange County Initiative.
And for the record, Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other abstentions or recusals? Okay, seeing none, do we have a staff report?
Good afternoon, Chairman Yost and a member of the board. Cheryl and I are here today to give you some background information about Be Well OC and also ask the board to consider authorizing the exploration of CalOptima participations at Be Well OC. Okay. So the current efforts that we have to improve the mental health system here in Orange County actually started back in March 2017. CalOptima was invited to a meeting hosted by St. Joseph Health to discuss the mental health system of care here in Orange County. The meeting was attended by many stakeholders, including county, cities representatives, hospital system, the National Association of Mental Illness in Orange County, NAMI OC, faith-based organizations, as well as many other key stakeholders. As a result of that meeting, there were 3 work groups that was created. They were system of care, infrastructure, as well as funding. The coalition have spent a lot of time in 2017 to work on multiple areas, and by the end of 2017, the coalitions accomplished several key goals, including creating a not-for-profit entity called MindOC to begin the explorations of financial resources to support the goal of creating a high-quality behavioral health system of care here in Orange County. The coalition also assisted the county in the search of a site for comprehensive mental health and substance use disorder treatments facilities, as well as also looking for or identifying potential facilities or location for crisis stabilization units here in Orange County. The coalition also spent efforts to build relationship with key stakeholders, as well as developing a MindOC continuum of care. The illustration here is an earlier version of the continuum of care, and it is a multidimensional focus with different focuses depending on the needs of the members. You have from crisis to the recovery on one side, and then on another spectrum from decline to wellness. And as you can see also in the center, it's focusing on navigation, housing, as well as community support services. Fast forward a little bit to June of this year, the coalition actually made an announcement that it's formally branded as called Be Well OC, and it's, as well as updating its mission statement to Orange County will lead the nation in optimal mental health and wellness for all residents. At the same time, Be Well OC developed a blueprint on how to fulfill this mission. The blueprint outlines the challenges that we're facing here in the county when it comes to mental health services, looking at potential solutions, the actions that we can take, how organizations can collectively make an impact, and areas that we should focus on our efforts on. And here in the slide, it shows the pillar for actions that were outlined in the blueprint, including system change, responsive and inclusive, aligned and accountable, be integrative, evidence-based and quality-driven care, and then fueled by MindOC wellness funds. MindOC is, the concept of MindOC as well as Be Well OC is really focusing on a leadership structure that is called distributed leadership. This particular model idea is to really allow small team to decide how they want to accomplish their objectives instead of just having one entity that really drives it. The idea is because it is a very complex issue and that no one organization here in the county can really be the lead. So this distributed leadership systems will allow all the key stakeholders to really participate and make an impact to the overall mission. In the blueprint, it actually outlines 6 what we call result areas. Here, the next 2 slides outlined what they are. The first one is reduce stigma. So the idea is to improve mental health awareness, attitude, understanding throughout the county. Second area is prevention and early intervention, and to make sure that all county residents have access to those type of services. The third one is to close the treatment gaps and improve access, and that focus on making sure that all county residents have access to program and services when they need it and where they need it. Number 4 is strengthen crisis response and that make sure that all Orange County residents has access to crisis support through a network of facilities, mobile teams, as well as digital tools. Number 5 is establish community hub. The community hub, the idea is to coordinate, to integrate, and including behavioral health as well as primary care. The last result areas is to align partners, policies, and programs to ensure that, that there are coordinations in the areas of mental illness, addictions, and homelessness, amongst others areas. So with that said, the Be Well OC actually held a 2-day summit at the Saddleback Church in San Juan Capistrano in August, early August, to provide additional information about the proposed blueprint and how to implement the results area. Again, it was a very well-attended 2-day summit, and CalOptima staff were there as well. The summits really encouraged all the attendees to discuss about the blueprint and how we can implement it. The summit, there was a lot of energy and enthusiasms and the agreements to work together to transform Orange County system of care. Also, the summit, what we learned is that there were some cautions of not to take on too much, making sure that we are addressing maybe perhaps some of the find early wins, such as using maybe low-tech solutions, so that we can identify some of the success early on. Creativity is another area that was addressed. People wanted to, very excited about forming new partnerships, particularly with partnerships with both public and private entities, and also looking at community engagement. So it's really important that participants really identify the needs to be aware of how the communities define success, as well as making sure that strategies are tailored where need to local communities within Orange County. So with that said, I'm going to hand it off to Cheryl, and Cheryl's going to take over.
Thank you, Dr. Poon, and good afternoon, Chair Yost and members of the board. As you heard from Dr. Poon, the Be Well Blueprint includes a goal of developing community wellness hubs, and I'm going to share a little more information about the first wellness hub site, as well as a proposal that staff has received from the Be Well leadership team. Oops. So essential to effective service coordination, the Be Well Blueprint includes 3 regional wellness hubs that are an integral part of supporting the mental health system of care. These wellness hubs will include a variety of services, including mental health, substance use treatment, and social services. The services will be based on the needs of the community where each hub is located and will be available to any Orange County resident based on their clinical need. Some examples of the types of services to be offered at the wellness hubs include triage, psychiatric intake and referral, substance use disorder intake and referral, substance withdrawal management, transitional residential services, and these are for adults in psychiatric decline who might require longer-term stabilization to ensure safe transition, for example, after a psychiatric hospitalization. Treatment services for people with serious mental illness and co-occurring substance use disorder, and an integrated support services center, which will include community-based services such as a mobile crisis response team, transportation services, social and community-based services, faith-based organizations, and education, employment, and legal services. Development of the first wellness hub, known as the Anita Street Project, came about based on the County Healthcare Agency's 2016 Strategic Financial Plan, which includes a priority to develop a campus site for integrated behavioral health services. And as part of this strategic priority, the county purchased a 44,000-plus square foot building, which is located at 265 Anita Drive in the city of Orange. The planning efforts for this site evolved in parallel with the Be Well initiative, and now a brand new 60,000 square foot facility is being developed at the Anita site in partnership with Be Well. The estimated cost of the project is $34.2 million. And as I mentioned at the beginning of my presentation, CalOptima staff has received a proposal to invest in the Anita Wellness Hub project with a request to contribute 1/3 of the estimated project costs. Specifics were not provided in the request as to how such an investment would be structured, what the return on such an investment might be, or how CalOptima members would specifically benefit from services provided at the Anita Wellness Hub. Be Well and Mind OC leadership have indicated that such details are open to discussion at this time. And so at this time, staff is recommending the following actions: to participate in the Be Well Orange County initiative by facilitating discussions regarding one or more of the proposed result areas, and to assess the feasibility of CalOptima's participation with the Orange County Healthcare Agency and various hospital systems in support of the Be Well Orange County initiative. And Dr. Poon and I are happy to answer any questions you might have at this time.
Questions of staff? There must be some questions. Dr. Kativi?
Oh, we're going to wait for somebody else to start. I guess I'll start. It's for the both of you guys. I'm curious to know a little bit more about the intake process, in part because I have noticed that previous projects that I've worked on where they have looked at ways to spearhead access for mental health. They would have an intake, let's say a licensed clinical social worker or nurse start the process for someone, let's say with a substance use disorder or a mental health disorder looking for assistance. They get the intake, which is simply just, your history and physical examination. And then they say, well, let's have you come back again when we consult with the psychiatrist or consult with the addiction specialist, or we'll refer you to this individual where you can get help. A lot of times I find we felt that project eventually died out and didn't work, as well as actually having the actual, because finding these guys can be so tough sometimes. Someone who's in an acute general anxiety or dealing with maybe a manic episode or dealing with an active heroin user at that time, they want the treatment right then, right now. And why? One, it helps reduce the ED visitations, ED cost, extended stay lengths, potentially overdose issues. And so when you have access to those individuals, you want to get them going right now. So can you explain a little bit more about that intake process for me? What does that mean specifically when it comes to this project?
I have a feeling this is awfully conceptual. I don't think we're even.
Sorry.
This is just exploring feasibility as to whether or not. I mean, we just allocated $10 million to recuperative care. They're asking for another 12 or 13 million for this, and I think maybe questions about governance structure, what role we would play, how this overlaps with services by the county, what county services, what CalOptima services are being provided might be more germane. Although certainly your expertise in substance use disorder is well noted and greatly appreciated. But I think we're a long way from actually nuts and bolts at this point. Dr. Nguyen.
Yeah, coming from a psychiatrist background, I mean, it sounds great. I think it should have happened years ago. What I mean by that is collaborative work among faith-based organizations, NAMI, all hospital systems. All this, I wish would have been done 10, 15, 20 years ago. And so it's about time. I think the conversation is healthy. It seemed like it took a really big collaborative effort to kind of get here. It's very grassroots, and I always appreciate that. So I'm all for it. I'm all for exploring, definitely. The one-stop shop deal, sounds great. It reminds me a little bit of a PACE center, for mental health, which is, I'm just drawing generalizing, patterns. But, I think the big thing is, as Spider-Man had said, with great power comes great responsibility, and the money it's going to be a lot, right? And, my wife's going to be really proud of that. But I think it's going to be very interesting. I mean, so questions that I have specifically is, have they talked about, the vision, the broader perspective at all on how anything regarding, let's say, you know, we want this commitment from CalOptima, 1/3 of the finances. What does that look like for us? Is that an investment? Is that something we're going to get returns on? Do we get a part of the facility? What does that look like? Because it's very broad, and it's hard for me to be able to get into specifics right now.
At this point, those kinds of details were not included in the proposal, but the Be Well leadership has indicated that those kinds of things are up for negotiation. So we don't know at this point whether we're looking at an investment, a loan, an outright gift, but those are all up for negotiation.
Supervisor Doe wanted to chime in on this. Maybe you have a little bit more insight, and Mr. Sanchez might have a little more insight in this also.
We both have been involved in this from the beginning in formation of the coalition. The proposal was made to contribute 1/3 of the capital startup cost. So that would bring this within the real estate purview of closed session. So at this time, I would propose that we table this item for the next meeting and then schedule it for a closed session. And at that time, all of the questions can be answered in a way that allow the board to fully explore the concepts. Staff doesn't have an answer, and frankly, leadership, we have Dr. Afable here, by the way, from Mine OC. But I don't want to pull him up and put him on the spot, because really, it's still in the conceptual level, and it is what we would like it to be. And so this is something that the board should discuss and in a closed session, and then come out with a direction to staff. It's my motion.
Okay, I'm not sure. I'll accept the motion. Is there a second? I'm not sure that I'm not sure that meets the criteria, though, unless we have a specific ask for a specific site for a specific dollar amount, and we're just discussing a real estate transaction. But if we're discussing a much broader policy issue, like whether or not CalOptima should be involved in this, what the governance structure should be, what our role would be, I don't know if I'll ask our attorney to give us some input, but I'm not sure that falls within the closed session purview.
Right, so the closed session exception specific to real estate covers the discussions regarding price and terms of payment of a particular transaction, and that would be the parameters of that closed session exception.
So the proposal, Mr. Chair, is to contribute 1/3 of the purchasing cost. We already have the location, so the question then is the payment, right?
Price in terms of payment, or what are permissible discussion closed session items under the real estate exception.
And at that time, what use of it can be weighed against whether or not we want to buy it. This is no different from what we do in our OCTA or the Board of Supervisors, which is we discuss on whether or not this is something we want to get into. And if we think it is, then we give staff direction to go out and negotiate with, in this case, Mine OC, on what would be the involvement. Are we leasing the property from the county, or are we buying, like co-own the property 1/3 with the county and the other stakeholders? And then what would be the governance structure, and bring that back to the board for us to decide. So that would be the direction that I would normally follow on the Board of Supervisors. And I'm asking this board to do the same thing.
Mr. De La Ricci, go ahead.
I think all those are reasonable questions, but I think, I thought that the second recommended action in terms of the assessment of the feasibility, et cetera, I think that some of those questions can be included within the context of that. If we have certain thoughts or ideas about how we feel governance should be best carried out, if we don't have a sense of that yet, I mean, we need to hear but those are things that I think that are open to us. If we have ideas or suggestions, my sense is that this is a group that's probably wide open to them. And as I looked at this thing, I'm probably being biased based on my own take on this thing. But I can't imagine why we wouldn't be extremely excited about this sort of a project This is big, and it's extremely important. I've watched, for anybody that's been around Orange County for a while and has watched the progress or the lack of progress in terms of being able to move forward at the level and the effectiveness we would wish for, particularly in the behavioral health realm, mental health and substance abuse and related. And I'm not saying that to be critical. It's just a tough thing. And I've seen a couple of efforts over the past 25 years that were very, very extensive, in terms of Alex's comment earlier. There have been. It just didn't get anywhere. This one has all the key players. It's got everybody who needs to be at the table at the table. I would commend the Board of Supervisors who probably weren't as engaged in those past efforts, but they're very, very much involved in this. I mean, that's going to be very important from a number of different perspectives. But this idea of a public-private partnership, where the hospitals are all brought into it, and where, and CalOptima, I mean, I just can't imagine something like this going on without us being a very, very significant part of it. When you look at some of the numbers, I thumbed through the booklet on
the member needs assessment. Yeah,
you look at some of those numbers. It's. I mean, we're talking about significant numbers of Medi-Cal patients involved here. But I love the fact that we're not simply isolating on a Medi-Cal system of care or a indigent system of care. It is comprehensive. It's collective. It includes the whole commercial realm as well. This is an Orange County issue. This is every resident of Orange County. This is their issue. And I love the fact that this is such a comprehensive, well thought out approach. Now, that's not to say that we might have some, as we go through an assessment like this, that we might have some ideas to offer that might further advance it and help. But I'm hoping that our internal assessment kind of brings those kinds of things out, and then we can have those discussions. I don't know that I have any burning questions right now. I'm anxious to see, from the Medi-Cal perspective, I want to see our staff's assessment and sense of what's important. And then I'm sure that'll generate some additional questions also. But I'm very enthusiastic about this. And I think that CalOptima has to be a central player, has to be heavily involved in it. The numbers in terms of our Medi-Cal patients that are in need of this care. The other thing is any organization in this county, if you take a look at their needs assessments, any organization, and you look at what is always at the top, it's all related to the behavioral health system. So whether it's individual hospitals who are mandated, the not-for-profit hospitals are mandated to do this sort of an assessment. County government does needs assessments on an ongoing basis. All of our community-based organization partners, they're all involved in doing. That's the common thread through all of them. This is the issue that everyone's begging to address. So this is a pretty bold approach at doing it. There's a lot more, I think, a lot more to be, fleshed out for everybody's perspective. But like I said, I'm very enthusiastic, very supportive of the recommended action today, and looking forward to what staff brings back so we can dig into it even further.
Mr. Penrose.
Not to pile on, but I do want to give kudos to the two of you, to Supervisor Doe, Mr. Sanchez, Dr. Rica Fable, who's here, for trying to pull off the seemingly impossible. If you look at any county in America, any city in America who's trying to solve this problem, who's not trying to solve this problem. Certainly families that are dealing with it, but you get law enforcement, you get healthcare agency, acute care is very much wrapped up into this, local providers, independent physicians, as well as network types, and individually, and a lot of nonprofits that are targeting these types of efforts or conditions. When you look at the whole world of mental health, it's so daunting. There's so much involved, and I've had a chance to observe some of the conversations as this coalition has been getting up and running, and I'm only more and more impressed as I hear the types of people that are coming together. These are big movers and shakers in Orange County, and when this works, I think we're going to have something that will be studied around the country, if not beyond. And so I think we need to be excited about it. I think now I'll put my Finance and Audit Committee chair hat on. And first of all, we're going to recruit you, Dr. Nguyen, to the Finance and Audit Committee. Your comments were spot on. I think given everything that I just said, we do need to be thorough in understanding what our capacities and limitations are. Certainly the funds that are in our general fund, what are they? What are our restrictions around how far we can go in spending them for efforts like this? How can we look at other sources of funds to participate? And that's what really I see as this type of feasibility study. So I fully support the efforts. I think there certainly are a lot more questions than answers, but the intent of this is something we shouldn't get in the way of. We should only encourage it.
Dr. Yost, if I
yes,
could.
please. Thank you,
again,
Mr. Sanchez, please.
Lee said, I don't want to pile on, but I'm going to.
Go ahead.
This effort is not without risk, but I think sometimes we have to take those risks to get something really innovative and challenging done that will truly affect this community. I see it firsthand. I know a lot of people on this board see that firsthand as well. And so I just encourage you. I'm encouraged by the comments that are being made. And I'm also encouraged by some of the more probing questions that are being asked. We need that at the table as well to make sure that this is successful. I think we have to do this right the first time. I've said that many times. And I've also said one other thing. It's always nice when we're all headed in the same direction. And it seems like for once, maybe we are on this one. So I strongly encourage a yes vote.
So we have a motion and a second on the table. However, I have a caveat to make. More discussion? No. I have a caveat to make, and that is that we will bring this back. However, I'm not sure that it meets all the criteria for a closed session. I think that it may have to be an open session. So I'd just add the caveat that we can discuss in closed session to the extent that it's allowed by law, I guess, would be with the caveat. Is that okay with the board as a whole? Okay.
Mr.
Yes.
Chair.
Go ahead.
Sounds like we have a consensus to move ahead. I'll withdraw my motion.
Okay.
And
just go with staff recommendation?
Exactly.
Okay. That would be a perfect alternative. Thank you.
Move regular staff recommended
You move the
action.
staff recommendation to move ahead with feasibility on this particular issue. Okay. And then second to that motion? Second, Mr. DiLuigi. All those in favor say aye.
Okay, this is just to assess feasibility, get involved, but we're not talking about finances quite yet, correct?
No. Correct. Yes, correct. Okay. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. Okay. Item 20, Madam Clerk, please read the next item.
Adopt resolution adopting a conflict of interest code which supersedes all prior conflict of interest codes and amendments previously adopted, and upon adoption, direct the clerk of the board to submit the code to the Orange County Board of Supervisors for review and approval.
And colleagues, this item is related to changes to our conflict of interest code. Are there any questions of staff on this? Seeing none, I'll take a motion.
Action.
Moved by Mr. DiLuigi, second by Director Berger. All those in favor say aye. Aye. Any opposed? That passes. Madam Clerk, please read the next item.
Authorize staff to explore policy opportunities to carve in dental benefits for CalOptima's Medi-Cal members in Orange County.
And Michael, would you please present this item? Or,
sure.
Oh, great.
I'm going to ask RF Sheikh to present the item. Yep.
Good afternoon, Chair Yost, members of the board. This item is regarding the exploration of policy opportunities to carve in dental benefits for CalOptima Medi-Cal members in Orange County. As a county organized health system, CalOptima provides most Medi-Cal benefits for eligible members in Orange County, which include primary care, specialty care, prescription drugs, long-term services and supports, and more. In recent years, through state and federal policy changes, certain Medi-Cal benefits that were previously carved out are now benefits under CalOptima. This includes adult day health care services, which were carved into CalOptima in 2012, mild to moderate mental health care in 2014, and behavioral health therapy services in 2015. Another transition is coming up in January, as your board is well aware, to integrate the California Children's Services Program, or CCS, to CalOptima. Even so, other Medi-Cal carve-outs remain, most notably Medi-Cal specialty mental health and substance use disorder services are provided by the counties, and Medi-Cal dental benefits are provided directly by the state through Denti-Cal, which contracts directly with dental providers. There have been efforts by the state to explore dental managed care in various forms, including mandatory enrollment in Sacramento County and voluntary enrollment in Los Angeles County. In both cases, the state contracts with dental managed care plans. And just this year, a budget trailer bill signed by the governor included authorization for a pilot that would integrate dental benefits into the health plan of San Mateo. Like CalOptima, health plan of San Mateo is a county organized health system. The pilot is expected to begin by July of next year, subject to appropriation funding by the legislature and federal approval as well. Today's recommended action would simply authorize staff to explore policy opportunities to carve in dental benefits to CalOptima. There are several steps involved, of course, which include working with local stakeholders, state advocates, regulators, and the legislature. Staff will bring back the results of this policy exploration to your board for future consideration and planning of next steps. Please note that the study of this issue does not obligate CalOptima to any particular course of action. Instead, we believe this action helps us get ahead of the curve as the state is continuing to make moves toward integrated care. And with that, I'll take any questions.
Staff. Sure, go ahead, Director Berger.
Thank you for the update. And I'm very, very encouraged about the steps that we're taking to at least explore this, to consider this. It's been way too long. We've waited too long. And frankly, it's a $2.2 billion expense nationwide that's related to tooth decay. So it's nice that we're now kind of putting that and including that as overall health care. Appreciate that.
All right. Other comments? Go ahead.
I just want to thank Michael and Arif especially for taking the board's vision and running with it. Sometimes it can be in different directions, but I just want to express my gratitude to you specifically, Michael, for hearing our thoughts and where we should go with CalOptima and running with it, Arif, and I appreciate that. And I think what Ria said is absolutely correct. In order to have a healthy mind, you got to have a healthy body, you got to have a healthy environment, and dental care is an instrumental and integrated part of that equation. And so I'm excited to see this is something that's feasible, something we can partner with the community on and potentially move forward. But thank you so very much for running with this, Michael, and Arif, thank you for stepping up.
Motion to approve. Moved by Director Berger, second by Dr. Dr. Nguyen. All those in favor say aye.
Aye.
Aye. Any opposed? Seeing none, that passes. We already heard item 22. Item 23, the CalOptima Foundation. Cheryl Merrick with various options. Do you have a quick presentation on that or discussion or?
Presentation. I'm Joe.
I think I'd just say it's an information item.
Okay.
And there are
it's just an information item, but
three options that we're presenting to your board.
Yeah.
One is, given changes to the use of IGT funds, we could leave the foundation open maybe give it another board, give it another staff, and really use it to do some fundraising activities. That's one option. Option 2 and 3 are very similar, which are both options to shut it down. Option 2 would be to expend the $2.8 million that is in the foundation now, and then initiate efforts to wind it down. And option 3 would be to move the $2.8 million from the foundation back to CalOptima, and then initiate efforts to wind down the foundation. So we just wanted to get some direction from your board. If there's a consensus around these options, we can bring back a COBAR at the next meeting with the option that you prefer, or any additional information.
Discussion. Director Penrose, this has been an issue for you for a long time. I'll let you start the discussion.
Hey, thank you, Mr. Chair. And I'd love to jump in and just add a little bit of insight. This has been a discussion at the Finance and Audit Committee. So, Dr. Wynn, when we orient you to the committee, we'll be talking about this quite a bit.
Way too many committees for me.
Just to remind you, we just had our financial audit, which was clean bill of health. The audit for the CalOptima Foundation really included one thing. It was the expense of the audit. And so the auditors did a good job of validating that we wrote them a check. And so you might look at this and think, well, yeah, but there's a purpose for the foundation. It was called out in the materials attached to the agenda. There was a purpose at the time that it was created. It served its purpose, and we've really had. There was an ad hoc committee that was formed 2 or 3 years ago to review this very question, and Supervisor Doe, I think you were on it with Peter Agarwal at the time. And that ad hoc committee decided, let's leave it in place. Let's see what comes out of it. Let's give it some time. Well, here we are 2 or 3 years later, and we really haven't found a purpose for the CalOptima Foundation. I'm not one for winding things down, but when we're just spending taxpayer dollars on keeping a foundation alive that we're not using, we could start raising funds. We could start doing fundraising. That would take creating a fundraising team. That would probably start competition with other nonprofits in Orange County where we're trying to do fundraising. We're all competing for the same sort of pool of potential donors. Could create other kinds of issues. And most importantly, we would need a why. We would need a purpose. What would we be raising funds for? And so we could get into more IGT-like conversations about that. Or I think, this really has run its course. I think this is long overdue. I know this is information item, we can't vote on it, but I strongly encourage the board to pursue option 3 and to issue a directive to staff to bring that back as a decision next time, but I'd love to hear if there's any conversation or opposition from the board.
Luigi, how about Be Well OC? I'm just kidding, go ahead.
Well, and I appreciate Lee's additional comments to it. He's been involved in the fact longer than the rest of us, and so he's seen it. But what I'm wondering about, Lee, is is there any potential or utility, if there is potential, to kind of folding this thing up and holding on to it as a kind of a mothballed foundation? I guess I don't have a sense of what is required to get a foundation started. And I've seen, and you have too, there are others maybe have too, I've seen examples where businesses, organizational structures have in fact been maintained in an inactive state and then are usable again in the future should something come up where there would be utility to that. And so what's your sense? Do you see any possibilities along those lines?
Let me give my quick answer to that, and I think yeah. Michael might want to jump in, but I know that when we stood up the foundation, it was done very quickly. The COREC grant came down the pike, and
so it's not a cumbersome burden.
It wasn't hard to create in the first place, so I'm not sure that there really would be much value in mothballing or.
Okay.
What you're suggesting is exactly what came out of the ad hoc a few years ago, which is let's sort of mothball this, but by mothballing it, you still have to have these annual audits done, and you still have to have a Finance Audit Committee. And so after 3 years, I think, of mothballing, we're looking at it. And
Then it's not truly able, you can't do it, you can't make it inactive. And
that's right.
Okay, that's fine.
This was set up to handle distribution of funds for COREC, which was the funds that were used for the transition to electronic health records, and we were doing that, but it couldn't be done through CalOptima directly. It only be done through a foundation. So we set up a foundation to do that. That project has run its course, and now we have an empty shell of something that hasn't been used for some time. So that's what we're discussing, just for everybody to understand.
And if it's easy enough to set up, then that's not a problem.
Okay. Go ahead, Gary.
Just one comment on that. Relatively easy to set it up. It does take some time to obtain, like in this case, it's a 501c3 organization, and so it does take a little bit of time to get the IRS to approve that. So to set up the corporation is relatively quick. To get the 501c3 status could take a number of months.
I should have said Mr. Crockett made it look easy.
Just a question, though. Is it possible to use something like this to help with the funding for something like Be Well OC?
This entity is set up for the purpose of the benefit of CalOptima. Okay, so to the extent that CalOptima funding or CalOptima's purpose includes Be Well, the short answer would be yes.
Go ahead.
I actually thought of that as we were preparing for this discussion, and my thought is there are so many nonprofits already involved in Be Well OC that have a 501c3, they have the ability to fundraise, and they have a fundraising team. We don't have a fundraising team. And so we would have to create infrastructure where infrastructure already exists within Orange County and as tied to nonprofits that are already involved in Be Well OC. So I think it's an interesting idea. I'm just not sure that it's the most practical solution for fundraising.
Yeah, we have over $1 million in it, though. 2.8, almost $3 million in it.
Took from the general fund.
I'm comfortable moving towards some sort of IGT project, potentially. But I think winding it down might not be a bad idea.
Okay.
It's just an information item, just so you get a sense from where the board is on it. So I don't think we have any specific direction from the board as it is. Go ahead, Lee. Do you want to propose a certain action?
Yeah, I think it is time for us to call the question, and in doing so, it would be a directive for you to bring back option 3 for approval or not.
Okay, I'm fine with it. So for our next meeting or whenever it's feasible to bring that back. Obviously, there's no hurry since it's been inactive for a while. All right. Chair and colleagues, staff has done a thorough job on the remaining information items that are included in your meeting materials. Unless there are questions, I suggest that we adopt items 17 through 20 as presented. Are there any questions on those items? You see none, they are filed. And board member comments. I'll start at my right with Supervisor, oh, she's already on, from Mr. DeLuigi.
Well, you know, this was a pretty action-packed agenda. Had a lot of good stuff on it. Some launching initiatives in behavioral health, launching launching initiatives in dental. That means we can probably walk and chew bubble gum at the same time and do a few things at once. I realize that we've got a full agenda, and that's okay. These are all good things, and they're all worth pursuing. So I was energized by today's meeting.
Director Berger?
Well, I just want to thank everyone for doing all the great work. We have so many complications and complexities around California healthcare management, and you guys are doing a fabulous job, so I just want to thank you for that.
So a post-Halloween hangover for me, just trying to hang in there today. But, first off, I wanted to thank all the staff, the MAC, the PAC, everybody involved, because, we sit here, we make decisions, but really the real work is in these committees and the time that you guys volunteer, and it makes a big difference. And we really appreciate that. And then, welcome to Dr. Ramirez as well. Thanks for dedicating many hours of your time each month here, with us in the future. It's going to be a lot of good, robust discussions, so we're very happy to have you. And, your experience and the staff speak very highly. And so we hear that from Michael, and we're very excited to welcome you. Thanks for joining.
Dr. Penrose.
Thank you. I also want to thank our MAC and PAC again, at risk of being redundant. I think this was a really good example, this whole process leading up to today, of how we should be engaging our stakeholder groups even more than we have in the past. So hopefully we can take advantage of sort of a newfound level of energy in that regard. And we had some good debate today, and probably coming up in the future. And I think that's a really healthy sign of a well-functioning board. So I appreciate each and every one of you.
Supervisor Dell.
Thank you, Mr. Chair. Our discussion today and all the things that we are looking into and being transparent and re-examining how we do things. I want to go back to what we did a year and a half ago with the member health needs assessment. And I want to thank again Michael and Cheryl. It's hard to take a look at yourself and do a deep dive and maybe expose things that may not be pleasant for us to see, but they never flinched. And in fact, in the ad hoc that we worked on together with Dr. Nguyen, they never hesitate. I think you weren't part of that too, Director Schoffel. And the information that I presented today is really helpful in shaping our decision making in the future. And some of that is not flattering, but I think that's what good decision making is. And I applaud this board, to not kind of shy away from that self-examination, and really appreciate your support on that.
Thank you. Director Schoffel.
Yeah, thank you, Mr. Chair. I would also like to welcome Dr. Ramirez to the team. Thank you so much. Really big shoes to fill, and looking forward to a lot of progress in the future. Also like to wish everybody a very happy Thanksgiving holiday coming up. Believe it or not, this is the first day of November. That's not that far away. We'll be driving home in the dark tonight and start to see the lights come out. And that's time of the year already. So very happy Thanksgiving to everybody, and we'll see you next month. Thank you.
Mr. Sanchez.
Just really quickly, so we discussed dental health, mental health. We've already got physical health down. Hey, what do you know? Whole person care here. That's it.
Dr. Kativi.
Welcome, Dr. Ramirez. It's great to have gotten to know you over these past couple weeks, and I'm excited for the work that you're going to be doing. For the public, I just got back from DC a couple weeks ago for the Millikan Institute, the Future of Healthcare. There was all the big stakeholders in the government, from Secretary Azar to Secretary Carson, and they identified really the future of healthcare and the avenues that need to be overcome. Number one being substance use disorders, number two being mental health access, number three being housing issues and housing instabilities, and number four, believe it or not, is food insecurities. Obviously, here in Orange County, we battle with food insecurities, but it was great to see stakeholders there as well, CEOs of Whole Foods, CEOs of Trader Joe's, there to talk about how they want to start going into these more urban communities to help people with food insecurities, because it goes back to the idea of a healthy mind requires a healthy body, requires a healthy environment. And so I love the fact that we're talking about all those issues, to be honest with you. So it makes me very hopeful, and to our stakeholders, I'm happy that we're working together to move the needle forward. So thank you so much, and happy Thanksgiving.
Cool. And Mr. Penrose, you had one other comment.
Thank you, Mr. Chair. I left one thing out. This is really important. Michael, in your CEO update, you mentioned this. I'm not sure that everybody in the room understands or really wants to understand the complexity of the quality assurance fee for the hospitals. It is something that took front and center stage last month. The program is being redesigned, and there will be winners and losers of the redesign. And the complexities were many, and a lot of decisions that were very hard at the state to make, but done for the right reasons, but were going to negatively impact both hospitals and I think networks in Orange County. Michael, as he mentioned in his update, went up to Sacramento, advocated for what's right in Orange County. And I'm not sure that it fixed everything, but it really meant a lot to, for sure, the hospital community, and I think beyond, that you were willing to do that. Thank you.
And just my own comments is just to tag on to that, I'm just hopeful that we can continue that partnership with our networks and to work together on that. And I look forward to that agenda item in the next meeting. And I also wanted to thank our MAC and PAC, particularly our MAC, because you really are why we're here. And although the board did not go with your recommendation, your input to the board was invaluable in the discussion. So please don't be discouraged and continue to give us your opinion and your thoughtful consideration of the issues. And with that, thank everybody for your attendance and take care. Thank you.